Dear friends, dear colleagues, I'd like to welcome all of you in this series of webinars organized in collaboration with the World Federation of Neurosurgical Societies, the MANS, and the CANS. As you all know, we started this webinar series on 29 May 2020. This is part of 100 webinar project initiated with beginning of the COVID-19 pandemic. Already we organized 68 webinars. We are glad that we had 3 webinars organized before in collaboration with the Neuro-Traumatology Committee of the World Federation of Neurosurgical Societies. And these webinars were organized in June 2022, January 2023, and February 2023. In this context, I would like to thank my friend, Professor Andrew Reisner, Chairman of the Neuro-Traumatology Committee of the World Federation of Neurosurgical Societies. Today is webinar 69, and it is the 4th collaboration with the Neuro-Traumatology Committee of the World Federation of Neurosurgical Societies. And it's a collaboration with the FLANC, which is the Latin American Federation of Neurosurgical Societies, and the MANS, which is the Mediterranean Association of Neurological Surgeons. I would like to thank my dear friend, Andres Robiano, co-chairman of the Neuro-Traumatology Committee of the WFNS, for such wonderful opportunity to have such collaboration. First of all, let me welcome all our distinguished speakers. I will go by the order by which they speak. Gustavo Patriota from Brazil, Fernando Colmina from Argentina, Oscar Alves from Portugal, Joe Gracioli from USA, Mario Janu from UK, Rodrigo Valiro from Brazil, Robson Amorim from Brazil, Andres Robiano from Colombia, and finally, Wellington Piva from Brazil. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time. Sharing your knowledge and experience with neurosurgeons across the world is well appreciated. Let me also welcome our distinguished moderators, Andrew Reisner from USA, Russell Andrews from USA and NASA, Alfonso Lagares from Spain. Special thanks to Professor Salvatore Shibaro for accepting to join the panel and to contributing to the discussion of this event. As you can see, the program is outstanding and it's divided into 3 sessions. In each session, we have 3 speakers. It's 1-hour session. At the end of this session, of each session, we have discussion. As we can see from this screenshot, until yesterday, we had 650 registrants over Zoom. Thanks to all our participants from all continents of the world who are joining this webinar series. To all attendees, we are glad to get all questions and comments, and it will be monitored by the moderators through the Q&A panel. This is the type of certificate we are offering. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies. However, if you like to get your certificate, please participate from the beginning to the end of the webinar for at least 3 hours. This series is organized either with the Education and Training Committee of the WFNS, with scientific committees of the WFNS, with neurosurgical societies, either regional, national, or continental, and sometimes with well-known universities. The maximum capacity of each webinar is 500 registrants. However, in some webinars, the organizing committee extend the capacity and open registration again for a limited time. This table shows the last 12 webinars and the number of participants. The maximum participation exists during the WFNS educational symposia. However, if we look at the last webinar, last Friday, we had 737 registrants. Not all of them participated, only participated 366. Certificates were sent only to 166 to those who participated for more than 3 hours. This series of webinars you can follow from the YouTube channel. However, not all the webinars are going to be uploaded to the YouTube channel. Again, this is a decision of the organizing committee. I'm glad to announce about the Pan-Arab Journal of Neurosurgery, and I'm glad to be the editor-in-chief of this journal. Submission and publication of articles are free. Webinar number 70, it will be organized next Friday. It's collaboration with the International Academy of Spine, and we are glad to have collaboration with Oscar Alves, co-chairman of this organization. As you can see, we have a galaxy of eminent neurosurgical speakers from all over the world. Webinar 71, it takes place on Friday, 31st March, 2023, collaboration with the Craniovertebral Junction and Spine Society. I'm also glad to have collaboration with Professor Atul Goel, who is president of this organization. Again, we have a galaxy of eminent neurosurgical speakers. I'm glad to announce about the 14th Asian Congress of Neurological Surgeons Congress, which takes place in Egypt from 28 to 30 November 2024. I'm glad to be president of this Congress and to work with Professor Yuko Kato, president of the ACNS. All of you are invited. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the mic to Professor Andres Robiano in order to give his welcome note. Thank you.
Thank you so much, Professor El-Ghandour. And as you mentioned, this is a very kind opportunity for the Latin American Federation of Neurosurgical Societies, specifically for the Neuro-Traumatology and Intensive Care chapter, who is now chaired by Dr. Wellington Paiva, who will be speaking at the end. And definitely we have, as you mentioned, an important group of speakers from the region, and also some of the associated persons that work with us regularly, like Professor Alves from Portugal. And the idea is to have a very nice conversation regarding topics of neurotrauma that some of them can be controversial, some of them can be well established, and we are going to have some updates related to these topics. So I hope everyone enjoyed this great opportunity, and welcome to everybody.
Thank you. Now, Professor Andrew Reisner, Chairman of the Neuro-Traumatology Committee of the World Federation of Neurosurgical Societies, is going to welcome everybody, and he is the moderator of the first session so that we can start the scientific sessions.
Thank you very much. Good morning, good afternoon, good evening, whatever the time is where you are. First of all, a huge thank you to you, NASA, for organizing this. And secondly, to Andres Rubiano. NASA, you kindly gave us this opportunity just a few months ago, and it really took just one quick little WhatsApp to Andres, should we do this? And it was an immediate yes. And we are very grateful for that opportunity. I must add that I'm sort of halfway through my tenure as the chair of the neurotrauma section of the WFNS. And honestly, the highlights of my tenure have been getting to meet and know people like you, Nasser, and of course, two amazing co-chairs, Andres Rubiano from Colombia and Laura Lipper from Italy. Laura is not on this panel, but I know that she has Zoomed in this morning. We spoke just half an hour ago, and so she's listening intently, and I'd like to extend my thanks to her. And especially a thanks to the audience. Thank you to all the students who are logging in. And before we get going, and we will shortly, you may wonder why all of us here, all the eminent speakers that Dr. El-Ghandour mentioned, the Dr. Rubiano and Dr. El-Ghandour are here. Why are we here and why are we doing this? And it's a quote that I've used many times, only because I can find a better one. And let me start off with a quote by Louis Pasteur. And he says, "Science knows no country. Knowledge belongs to humanity, and it is the torch that illuminates the world." And as NASA has just said, we have 9 torches who are going to give wonderful talks today. starting off with our first speaker, Dr. Gustavo Patriota from Brazil. He's going to speak on hinge craniotomies. And if I may just quickly mention, again, at short notice, in fact, how short, yesterday, I approached an expert on the topic, Dr. Salvatore Ciavarro, to be part of this panel, because he's done a lot of preclinical animal work and clinical work on hinge craniotomies. And I know that we all would very much appreciate hearing his opinion. So with that, perhaps over to you, Professor Patriota. We're interested to hear what you have to say. Over to you, Gustavo.
Okay. Good morning, all. Thank you for being here with you and take my opinion about hinge craniotomy. I will compare this. So, my talk about hinge craniotomy. That's a smart form of cerebral decompression. Is new, and this technique was described by 3 independent groups about 2007. In Brazil, we have 2 groups, Valença, that concern about the bone flap, and Almir Andrade, that concern about axonal stretching too. So these groups, these 2 groups thinks me to organize this class and to talk about some terms. The use of hinge craniotomy requires further evaluation. That's what was written in the comprehensive craniectomy question. So there are many forms that you can make a cerebral decompression, but what the degree of decompression we need? We need to expand the dura mater, or we need to expand augmentation the cranial? That's a question. And when we are doing a craniotomy, a hinge craniotomy, we take all. But when you are doing a craniotomy decompressive, you put the bone out and you open the dura mater. So there is a questions. There is different forms: craniectomy, decompress, and hinge craniotomy. This is a question. The size of craniotomy. If you do a big size, a larger size, more than 14 millimeters, you can achieve 150 millimeters. That's what you can need in stroke. But in neurotrauma, you can need less than 150. So a hinge craniotomy, you need less. You don't need 150 cc. So you can think about this. This experimental study can tell us about when you open the cranial, and when you do an elevation of 10 millimeters, you gain about 7-8 cc. If you do a 20, if you do a 220 elevation, you can gain about 160 cc. So this work make you think about the size of the craniotomy and the elevation of the bone. This was the first work in hinge craniotomy, but we can show you that the bone was fixed in the inferior part, and if you have a temporal hernial, uncal herniation, this is a difficult form of the temporal decompression, because the inferior plates will compress the brain. This technique has a potential to eliminate a secondary surgery. So these authors think the concern was about the second surgery. This work of ridge craniotomy do a white plate, but the size of the craniotomy is small. We don't have a temporal decompression. We don't have a large craniotomy. White plate is a good plate, but the concern of a large bone flap is not in this work. The concern is about to prevent the bone flap. In window craniotomy was made by Valencia. This is a large craniotomy, but the dura mater is open like a star. The author don't think about the axon stretching. You can this kind of open the dura mater, you can have axonal stretching. That's important concern in range craniotomy. So, but the bone is a large bone flap. The dura mater, the technique to open the dura mater is in star question, and the concern of this author is to do not have the second surgery and to preserve the bone flap. Professor Almir Andrade did this paper, and this paper ele think about the bone flap and the axonal stretching. In the selection case, he did patients with more than 10 millimeters of midline shift, but in the results, we see that midline shift of about 11 and post-operative midline shift of about 5 millimeters. So he cannot zero the midline shift in the post-operative tomography, probably because the indication of patients more than 10 millimeters. His technique, he used vertical durotomies that could expand the brain. These durotomies has about 5 millimeters. So, but you see that there is a large craniotomy, and the durotomies are more small. The concern, he had the mortality compared with standard techniques, but he introduced the concern to preserve the bone and to see about the axonal stretching, which is the best range craniotomy. There is a neurosurgical review, recently a neurosurgical review, and I think that there is a selection, a perioperative selection of patients with midline shift of about 5 and 10 millimeters. The technique have to have a large craniotomy, and the durotomies that span the brain about 10 millimeters. So you can achieve the goal, the best technique. How to expand the brain 5, 10 millimeters. We have to do a large craniotomy, the high 5 technique, 5 bullholes to do a large craniotomy of about 14 millimeters in the axonal axis, and the durotomies of about 10, 15 millimeters, 5 durotomies that you can achieve. So see this case, patient with temporal brain contusion and lamina subdural hematoma with midline shift of about 8 millimeters. And you see a large craniotomy, 5 durotomies for vertical of about 10, 15 millimeters, and one horizontal in the temporal region. So you can put the pericranial flap, and you can put the bone flap linked on the vertical, on the upper side, and you need the plates to avoid the retirement of the bone. This is operative midline shift. You see the quadrigeminal, the compression, the cistern is the compression, and the midline shift. The bone open in the post-operative tomography, and you control intracranial hypertension. So, in my expert opinion, that range craniotomy is a good treatment, is a smart treatment, but we can select well the patients, and you have to do the techniques to preserve bone and to avoid axonal stretching. So the best indications, in my opinion, is acute subdural hematoma with septal deviation greater than hematoma thickness, 3 millimeters, and midline shift of about 5-10 millimeters, multilobar gunshot wound with midline shift 5-10 millimeters, non-surgical multifocal contusion with midline shift 5-10 millimeters, non-surgical traumatic intracerebral hemorrhage with midline shift 5-10 millimeters, and Marshall 4 with midline shift between 5-10 millimeters. If the midline shift is greater than 10 millimeters, this technique could not resolve the midline shift. So the compressive should be the best technique. So
Thank you, Gustavo. That was a very interesting talk. And I just wonder if we could just change things up a little bit. Professor Salvatore Ciabarro has written extensively on the topic. I have actually 2 of his papers in front of me just to refresh my memory. He's done a very nice preclinical study looking at this technique in dogs, I believe, and also some cadaver specimens. Salvatore, while this is fresh in everybody's mind, would you mind commenting? Because you truly are the expert, and I think my best contribution is to keep quiet and hear you speak. So over to you.
thank you.
Thanks, Professor Reisner. Can you hear me? Everybody can hear me?
Yes, very nicely.
Okay. Thanks very much. And very nice, Professor Patriotto, for your overview. That's, I think, is something that nobody knows as the hinge cranectomy has for a long time not been utilized. I would say that the problem about cranectomy, hinge cranectomy is what's the complication? The complication is that it couldn't work. So we need to proceed to a decompressive cranectomy. Otherwise, it's a very nice, I would say, technique. Now, the problem is why since 20 years we have been working on this technique. We started using the floating bone flap, and with very long stitch. Afterward, we started using to elevate equally all the sides, all the board, using the L plate. But anyway, every time we need to, even is just a small operation, reoperate the patient just to put the flap back. So, but what actually we have been working also is that what is important is that the brain doesn't work the same way when the skull is open, when it's covered. So I've been working a lot about perfusion, brain perfusion, and brain metabolism with PET scan and MRI perfusion. So I think that the interest of this technique is about to protect brain and to make it working as much as we can properly. As you know, there are many secondary lesion, many lesion related to the trauma. So I think that this technique is very good. Is also a very nice interest in underdeveloped country, as you don't need to put a new cranioplasty and to, we can just reduce cost. So now I think that what actually we could do is to launch. We can use this platform to launch a randomized trial that never been done. And see, if you have a look at the literature, people say that between 2 and 6% the inch craniectomy failed. So I think we should try to find also the best indication, as you already said, but I think there is no really matter of, maybe we need also to reduce the midline shift, but probably the problem is reduce the midline shift, reduce ICP, protect the brain. I think there are many issues going on. So I think the best would be maybe to organize something different, and maybe through Professor Reisner in the Neurotrauma Committee, maybe organize a randomized trial, or try to put all our force together to solve out the problem. I think this is, I think I'm really interested in this technique, and this is really something really smart. I think it's smart. Who did at first was very smart, but now the problem is there are few problems to be solved out. I think we are here for this. Thank you.
Well, thank you both for your expert opinions and comments, and absolutely, Salvatore, we'd love to follow up. That's one of the functions of the WFNS, is collaborating with projects across countries such as this. And maybe what we could do is just email each other afterwards. And of course, any participants are interested, they'd be more than welcome to get involved as well. Any last minute comments from you, Gustavo or Salvatore, before we move on?
Just I want to say that the winch is a smart technique, and all of us need to select the best case, and think that this technique has limitations. We do not apply this technique for all patients with intracranial hypertension. The selection is the best way to do the right thing.
Thank you. Thank you. Good point. Salvatore, let me give you the last word, if you want.
No, I think is the Professor Bardo is right, but I believe that if maybe we can develop a new technique where the bone flap is elevated equally, I think that we could be also applied to large decompressive craniectomy, not just patients, just patient need for, I don't know, brain contusion or acute subdural. I think that if we can refine or maybe improve the technique, it could be used. I'm not sure. We should prove it anyway. We can use it in very large indication, even in the compressive craniectomy for brain injury.
Perfect.
If I
Well,
may,
thank you.
Just
Yes.
briefly, Andres and I, we were speaking about it in the clan that was here in Miami Beach. few months ago about the augmentative craniectomy, which is the symmetric elevation from the bone flap. After we saw the presentation from Professor Luigi Valentino, you might know him. So we started collaborating about a project, a multicentric project with this. So the idea is like, as you described, an L plate that would keep the bone elevated, more or less the same. And then we evolved talking about maybe a retractile plate that you could customize as it goes to have a similar. And the beauty of this that we saw is that the reconstruction can be done at bedside, maybe with local anesthesia, that you just go where the plates are and then you just retract them back or substitute them. I think it's a great idea.
I agree, but it's very nice. But the problem is scar tissue. If you carry on for 3 weeks, 4 weeks, it's not easy to do it very easy at the bedside with the patient. Scar tissue sometimes actually avoid the bone flap come back. We have been trying. I've been trying to use it, but we couldn't do it. We couldn't take out the L plate and very easily. So I think it's a very nice I think topic we can work on.
Therefore, maybe a retractile plate instead of replacing, you just tune back and then let's see.
Excellent discussion, and I maybe I'll end off with a comment and a question. As a pediatric neurosurgeon, I work very closely with plastic and reconstructive surgeons on children with facial deformities. And I don't know the answer to this question, but I wonder if they aren't a little bit ahead of us with the distractor devices that they use, some that can be removed locally, and frankly, even some very innovative techniques such as absorbable plates and screws that do not have to be removed and that get absorbed with time. And maybe that's a discussion we should all have after this, but very interesting. Thank you so much. So with that, it's a huge honor to introduce Professor Fernando Colmena from Argentina. Fernando's had a long interest in traumatic brain injury. I just read an interesting paper that he wrote on endomedicine and raised ICP. He's participated in multinational studies looking at the effects of nutrition. And today he's going to speak to us on second impact syndrome, something I particularly am very interested in. Again, taking care of children who have sports and other concussions, and that's our big fear, is a second impact. So over to you, Fernando.
Okay, thank you very much. First of all, I would like to thank to the organizing committee, mainly Professor Rubiano, for the kind invitation to the prestigious committee. Okay, I'm sharing my screen. Could you see it? Okay. I would like to talk about this interesting entity, maybe controversial, but with interesting for our group. This is a very interesting topic. First of all, the definition. The second impact syndrome was described by Sander and Harbuck in 1984 and 1984. They described this entity for initially minor trauma, concussion, and second impact with catastrophic consequences. Syndrome, second impact syndrome is a true rare condition with a rapid brain swelling and occurs for result of repeat TBI before the second trauma, before symptoms have been resolved. The second injury is habitually not severe, but it could be, but results in devastating effects. There are just a few reports because the rarity of the condition and pathophysiology not well known. Most of the cases are young people, mainly males, engaged in contact sport, boxing, ice hockey, football, rugby. But one important point is this syndrome must be differentiated from chronic traumatic encephalopathy. This is in relation with repetitive head injury, and this is more common in retired professional athletes with clinical, behavioral, and neuropathologic findings. It's different to this the entity that today is talking. This is an original paper by Sanders and Harwood, one young man, 17 years old, with two trauma, second trauma 3 days with the concussion after first, and with after the second concussion, the result was devastating, and the patient was died. What is the definition with what's the current definition to use the second impact syndrome in sports? Mainly with the second trauma, the second concussion is produced before to the symptoms of the first has been resolved. This is a accepted definition. This is an interesting paper. The 2015 is in relation to the physiopathology. Is a very, very interesting point. What is the definition of concussion? Complex pathophysiological process affecting the brain, induced by biomechanical forces. Is the wide definition. It's not precise, but the temporary metabolic derangements arise from shift on ion channels. And this is in the concussion. The concussion produces a state of altered cerebral metabolism with a decrease of protein synthesis and oxidative capacity. And this cascade neurometabolic produce activation of N-methyl D-aspartate. This is very interesting for I talk about at the end of the lecture. And the calcium influx conduct to uncoupling oxidative phosphorylation, and this produce reduced oxidative capacity. The effect of second traumatic brain injury may be synergistic rather than additive. And this is the inability to auto-regulate cerebral perfusion pressure produce prompt massive cerebral edema. This is a controversial entity. There is some paper with a myth of reality. This is a question for the panel. I would like to show you one case in our hospital. This case was, I point out, was the diagnosis and review was performed by our neurointensivist, Perla Panque. At our hospital, we had the opportunity to diagnose and treat the case that met in our thoughts the criteria to second impact syndrome. A 28-year-old male boxer who during the round received a knockout punch with severe TBI. The patient is referred from another nearby city. He's admitted to our hospital with endotracheal intubation, sedation, hemodynamically stable, Gallagher score scale 5, myotic pupils. And the patient had a history of previous TBI a few months earlier, even with a small subarachnoid hemorrhage. And in addition, another concussion. And the most important point was the symptom never had been resolved, and the patient had headaches, fatigue, dizziness, and treat with intake of analgesics. After initial stabilization, brain CT was performed. This is a small video with the case. One second. This is a small video of the fight. And as you can see, the kinetics of the punch is no high. Even the fall are spectacular. We received 1 hour later this patient, and this is the original CT scan with a subarachnoid hemorrhage, brain edema, and midline shift. Midline shift 6 millimeters, and the width of the subarachnoid hemorrhage was 3 millimeters. Subcaloric index, highest subcaloric index. The neurosurgeon on call decided to do the primary decompressive craniectomy and evacuation of the subdural hematoma, and the result was good. This is a post-op CT scan, but in the next CT scan, we can see in the post-operative follow-up, a non-invasive ICP measure was performed. No increase of ICP was observed, but there were left side oscillation, which could be related to autoregulation failure. And 20 hours later, this is a new CT scan with you can see a image of infarct in posterior cerebral artery, middle cerebral artery, and anterior cerebral artery bilateral. This is angio CT to looking for the vascular lesions, but we can find these vascular lesions. This is a diffusion wedge image in MRI, and you can see the new infarct without relation with the impact and the evolution and the treatment of the patient. This is a FLAIR and T2 with a complete infarct in cerebral posterior artery and an incomplete in middle cerebral artery with respect to perforators of M1, and bilateral infarct in anterior cerebral artery. This is an angio-CT without a lesion in the main trunks. Okay, one mention only with the subdural hematoma in boxing is the consequence is not the same in different cases, but sometimes it's very devastating trauma. One case in this pair is similar to our case, and with infarct after the compressive cranium. The patient had good evolution, and fortunately, and the last picture is after cranioplasty. Okay, second impact syndrome in football, American football is a rare and devastating condition. There are some reports. Discussion and question. Second impact syndrome, is it a myth of reality? For our vision is reality. How can we explain the devastating effect of the second impact? The explanation is for the pathophysiology of the entity. There would be a temporal window after the first concussion in which there is a vulnerability of the brain without a good autoregulation. How can we identify the group of athletes at risk of second impact syndrome, and how can we identify the group of athletes to be banned from the sport? This is a guidelines with the classification by CAN2 in the different grades of concussion, and this is a practical guideline to identify the patient at risk. This is interesting paper with a study with spectroscopy, and the level of N-acetyl aspartate, the level of N-acetyl aspartate decreased after concussion, and the elevation is in weeks, sometimes months. And it's a good marker in the scatter plot demonstrating the white marks are the one concussion, black two concussion, and the recovery in the days post-injury. In conclusion, second impact syndrome is not a myth, it's reality. For this reason, we must continue investigating the pathophysiology for a better understanding of this syndrome. The limiting knowledge of this entity and other long-term consequences of concussion highlight the need for accurate diagnostic tools and effective management strategies for this patient. But what is our role of the neurosurgeon? In our point of view, there is a need for the neurosurgeon to have knowledge of concussion, as they are often involved in the initial management of TBI to identify potential complication of repeated concussion and to offer appropriate diagnostic and treatment. This is our city in Córdoba, Argentina. Thank you very
much. Fernando, thank you for a fascinating talk. It really is a subject that's incredibly important and has not been studied adequately enough. Real quickly, that slide that you put up towards the end, I think I'd like to address the first 3 points that you had. Is this myth or reality? 100% agree with you, it's reality. I've seen it once or twice, more than once or twice. I just can't explain why it hasn't been written up more than it has, but there we have it. The second question, how can you explain it? And the short answer is, I don't really know. But the third question is the pathophysiology. Again, the short answer is, I don't know. But I think we have an inkling and a sort of model, different set of thing is what we see in pediatrics more commonly than the second impact is the shaken baby syndrome. And those babies are shaken by the time they come to us neurosurgeons more than once. Usually. And we've done some research on it, and particularly we've looked at inflammatory markers. And it's those inflammatory markers are overexpressed in these abused children than the other children come in with a single accident from like a motor vehicle accident. Secondly, those kids that are abused, just like the second impact syndrome that you take, their recovery is much longer. Their outcome is much worse. And I can go on, and I just don't want to say that, but it would be maybe interesting for you just to look at that literature as how badly these people do. And again, not the same as the second impact, like I think we're discussing after 2 concussions, but similar. And I'll stop right there. Anybody else in the panel want to make any comments? If I could add one of the last thing, Fernando, the role of the neurosurgeon, I'd add one more thing for those that have got the time and the interest and the access to the community, especially the pediatricians, is to play a role in prevention and publicize that this is a problem. And as is done in Seattle, they've got the Zachary Lysted rules, thanks to the pediatric neurosurgeons there, that got state rules to say that if a kid has a concussion in sport, they need to be taken out, need to get back in. So those return to play rules are mandated by the states and probably should be.
Okay, I absolutely agree with you. Then 2 points. Our role, for me, is today in the emergency rooms, it's very common to have emergentologists and with the control of this patient, but the neurosurgeon don't have to avoid to be in contact with the patient. With in the education of the trainers, and it's very important understanding and study of the concussion and the results. The second impact is the proof. We have to know the pathophysiology and the understanding of this. And it's very interesting your point. The second Mabry syndrome is maybe yes, and the evolution depends of it's very clear. There is a vulnerability of the brain after the symptoms have been resolved. But which is the origin of the symptoms of the concussion?
Right.
Metabolic disorder, of course. And we have to keep in mind this situation to mainly to the advice of the athletes of the young people to return to the activity, mainly in the contact sports. Yes.
Thank you so much, Fernando. We're running a little bit behind. No, thank you so much. Interesting discussion. Thank you for your talk. Just like Gustavo and Fernando, we have a third world expert to come and speak to us, Oscar Alves from Portugal. Oscar has been interested in traumatic brain injury for a long time, and he wrote a very nice paper back in 2003. I don't know if you remember, Oscar, with Russ Bullock on basal gyrotomy, which I've read and kind of follow that technique. So thank you for that. Oscar is going to speak to us on the surgical management of chronic subdural hematoma, a wake mini craniotomy. Over to you, Oscar. Thank you. We are honored to have you here today.
So good afternoon, everybody. Thank you for joining us. Andrew, thank you so much for your invitation. Same to Andres. You're really doing a great job of expanding the education at the worldwide level. So my topic today is very simple, nothing like the strong basic research we did with Ross Bullock in Richmond. It's just about surgical treatment of chronic subdural hematomas, awake mini craniotomy. Just a little word about epidemiology. We have about 1 to 2 cases per year on 100K persons. If you are older than 70, you get much more cases. You get 7 cases per year per 100,000 inhabitants. But the importance of the topic is that the increasing incidence is evident for several reasons that I'm not going to discuss here. Mortality, it's not a big problem of this pathology. Can rate from 0 to 8%, but complications are really a problem. And they can sum up to 25%, which means 1 in 4 patients that we operate, there is a possible complication. Of course, indication for surgery is very important, relies on patient selection, and I can show you here 2 examples. On the left side, a patient with chronic subdural with neurological deficit that I managed conservatively with a good outcome. And strangely, this patient on the right with no neurological deficit, but a huge subdural that we did a mini craniotomy. So there are no studies to evaluate the midline shift regarding conservative or surgery treatment. Also, the thickness of more than 1 centimeter is somehow arbitrary. There is no evidence-based hematoma cutoff size for surgery. So we have to rely a lot on our sense as clinicians. So what are the goals for surgery when you decide to go for it? You have to decrease mass effect. And probably I was taught when I was a young resident that it's enough to do a subtotal drainage. You don't need to remove all the clot to get a good neurological recovery. However, if you think about the pathophysiology and the cycle of fibrinolysis, you really need to do as much as drainage as you can do, and with abundant wash. Because the risk of recurrence is increased when the concentration of fibrinolytic factors remain high in the postoperative drainage fluid. So it's really important to drain as much as you can and do all the wash that you should do until it becomes really clear fluid. And another very important topic is the neomembrane opening and release. There is a high content of plasminogen and plasminogen activator within the outer membranes that enhances the fibrinolytic activity. So when you're facing a scan like this with a lot of membranes, and you try to identify if this is the inner membrane, if this is the cortical membrane, you are looking to a burr-hole, like this lady doing some espionage on the other room. So I think I believe in some cases that I will specify which it's of utmost importance to open all membranes and cavities, sometimes including the inner membrane. And I think this can only be done safely with good visualization, which is offered by a generous bone removal. That's dangerous if you try to explore neomembranes through a small burr hole. So if you look at the technique, there is no significant advantage of one technique over the other. I'm citing here just a systematic review. So my approach, my surgical management of chronic subdurals is really based on complication avoidance and taking into factors of the characteristics of the hematoma. And what are the complications? The most severe complication is recurrence. 1 in 4 patients can recur the chronic subdural, which means that the patient improved of symptoms and later deteriorated. It happens in 7 decades of life. And we all know that this can delay patient rehabilitation, sometimes in a way that it can lead to big problems, to big disability, or even the death of the patient. So everything needs to be very quick when you're dealing with older patients with chronic subdural. The risk factors are larger hematomas. They tend to recur more than smaller hematomas, and I cite here the statistics. Bilateral hematomas also higher recurrence than unilateral hematomas, probably around the double. And whenever you find a mixed density of blood on the CT scan. And actually the hematoma CT pattern can predict the chance of higher recurrence rate. And if you have more homogeneous hematomas, these will recur less, and probably those are the ones that can respond better to less invasive technique. Whereas if you have hematomas with different densities, which is the separate, denominated separate with a clear boundary between the densities, or laminar, where you have a thin high density layer along the inner membrane, these are the ones will probably recur more, as you can see on this study from 2001. Also, if you choose the burr hole technique, you should insert a drain. It's the only class 1 strong recommendation that you can find in chronic subdural treatment. In case of burr hole technique, drain insertion reduces recurrence by 60%. However, if you do burr holes, you can have drain complications, risk of hematoma if the catheter is forced too far away, like you see in these anecdotal cases here. You can have brain laceration and perforation, or you can even traumatize the neomembrane and get a postoperative hemorrhage, acute hemorrhage. Or it's also a risk factor for a postoperative impairment. So if you plot all the techniques together, it seems that the less you do, the higher recurrence rate you can get and reoperation you can get. If you are more invasive, like here with craniotomy, you have 100% improvement of neurological condition. And so this is quite a good rationale to think about mini craniotomies on this patient. And everybody looking at the clinical condition can be a candidate for a mini craniotomy. I don't think a bilateral subdural is a contraindication, or patient with a GCS lower than 12, or under anticoagulant or antiplatelet, or if you have severe cardiopulmonary disease. These are not contraindications. Actually, if you have comorbidities, this can be even a good reason to do a mini craniotomy. I don't remember actually of doing on my career any chronic subdural with burr holes as far as beyond residency or under general anesthesia. So we have a very good experience on doing burr holes on local anesthesia for chronic subdural. And if you look at this paper, there are not many papers in the literature. They found that between GA and local, there is no difference really there is no difference in the other conditions, in specific conditions, but the number of complications is really smaller in the local anesthesia group, 6 to 29, which is really significant. So I think it's something you should avoid, general anesthesia in patients with chronic subdural hematoma. But can you do it not only the burr hole, but also the mini craniotomy? I think so. I mean, what are the requirements for awake craniotomies in general in neurosurgery? If you have an easy accessible pathology on the convexity of the brain, this is the case. If you have experienced neuroanesthetist and previous experience with burr holes and the local anesthesia, if you have a reliable air holder system, this doesn't need to be very complicated, as I will show you, to prevent inadvertent brain injury in case the patient moves on the table. The patient has to be comfortable on the surgery. It's usually a quick surgery. We don't do any scalp block. It's just local anesthesia in the marked incision, subcutaneously and subperiosteally. And because of the patient can complain a little bit of noise when you do the burr hole, we can do just very light sedation with propofol. This is one of our patients, very, very rudimentary head holder. This is the skin incision for the burr hole, and then we'll connect the burr hole. And this is the patient talking to us. So what are the advantages? Is to reduce the risk associated with general anesthesia with tracheal intubation, especially in older patients with significant morbidities. The papers we have about awake surgery in other pathologies in neurosurgery tells us that it is safe and well tolerated with high rate of patient satisfaction. And very important, quick recovery from anesthesia, no ICU admission cost, reduced length of stay, and quick transfer to rehab. This is just one of our cases that we manage with a very small craniotomy, opening the dura, exploring the membranes, a drainage. This patient actually had a first surgery with 2 burr holes by another team, draining the posterior burr hole. Needed to have a second surgery with a 3rd burr hole on the temporal area. And then eventually we did the craniotomy. We don't leave a drain. And this was the final result. So in conclusion, awake mini craniotomy in chronic subdurals, for me, is the primary treatment if you have mixed hyperdense with acute solid or chronic subdural hematoma. If you have significant membranes, if you have a recurrence, as I show, or even a calcified chronic subdural, obviously. So I don't find much literature about the topic, actually. This is more kind of an expert opinion, but in our hands, it's the best technique to avoid general anesthesia complications and surgery complications, namely recurrence and drain-related issues. And we had no cases to convert to DA. Thank you.
Thank you very much, Oscar. That was a fantastic talk. Especially intrigued by the head holder that you had on that patient on the stretcher, and I'm looking forward to seeing that written up as a surgical technique one day. So thank you. In all seriousness, Oscar, if I could give you a question from the audience, and here goes. It's from Sakchai. Do you recommend any perioperative care to minimize the risk of recurrence of chronic subdural hematoma?
Right. So I mean, this is a kind of a generic question or related with the mini craniotomy.
I think I'm going to guess it's more generic question.
More generic, right? I mean, there are several tricks that you should use. First, it's really wash and get a really clear fluid from at the end of your operation. I think there is good evidence that using drains, and you normally use 2 drains, one posterior, one anterior. It avoids some of the recurrence. And of course, when you need to open all the membranes with the craniotomy, I also always use the frontal drain to get rid of air. So I get installation of saline on the posterior burr hole drain and raise the drain and get as much as I can the air from because having attention to pneumocell is also a risk factor for recurrence. And of course, all the care that you should have handling the drains, not forcing the drains. If you have already a drain that expanded a little bit too much, either do not insert the drain or insert the drain while you are irrigating a little bit. So this will create some room to insert the drain more safely. And if I don't forget something, this is my techniques to avoid the recurrence.
Thank you. All excellent points. Thank you so much. Any of the other panelists have any comments before we move on to the next session?
Yes, if I might, typically, for instance, beautiful presentation. I just loved it, the technique and the approach. And it certainly you have much less anesthetic complications once you're able to perform this under local sedation. So typically the approach we have for hematomas with septations or multiple membranes that you cannot address, we always try boreholes first, and we combine with MMA embolization, like the middle meningeal artery. We've been having very good results. I mean, they disappear after we cut off the supply for the chronic process. I don't know if you guys use as well the endovascular technique combined.
No, I read the literature, but I have no experience with embolization. I mean, I think the logistic is pretty heavy. Sometimes you don't have the resources. What I read from the literature is good results actually, but we don't use it. We don't have the resources or the capacity to use it. But as I said, I didn't find in the literature good papers on the topic, awake craniotomy, mini craniotomy. So if you guys are interested, we can join together and put our cases together and get out the paper. And this would be a good contribution from this webinar.
Yes. Second good contribution. So thank you for that.
Yes.
Thank you.
Sorry about we did recently an institutional audit about recurrence of chronic subdural, and we looked at 2,000 patients over 25 years, and the only factor that was related to reduce the recurrence was just put a drain. So no double barrel, not put the mini craniotomy, nor taking out the membrane, just to put a drain. And also, I would thank you. The case you presented is one of my cases from Vladislav. One of my cases that we actually, it was a disaster. The case you showed in your presentation. It was on my cases since 12 years ago. Yeah. Thank you.
Thank you. I have here Dr. Ndero, which asks what the GCS cutoff for awake mini craniotomy. Of course, you need a collaboration of the patient. Otherwise, you cannot call it awake craniotomy if you're going to do some sedation. But the concept of mini craniotomy you can apply to whatever patient you have with the conditions that I showed, with the multiple density of the clot, with the neomembranes, etc. But in order to be awake, the patient needs to be really a GCS 14 or 15 that is reliable, at least to cooperate what you are doing.
Thank you very much, Oscar. That was fascinating.
Thank you.
More to come. Thank you. Before we move on to thank you very much. That's the end of the first session. We're about to go into the second session, and I got WhatsApp by Russ Andrews, who's going to moderate it. There's apparently storms in California and his electricity is out. So Professor El-Ghandour and Professor Rubiano, if you would like me to substitute as a moderator, I'm happy to continue. 100% your call.
Yes, please, Andrew. Go ahead, please.
Thank you. Beginning of the second session, we're off to a great start. Joe Gracioli is going to speak to us. Joe is a very respected neurosurgeon from Miami, and he's going to speak to us on one of his many interests, trauma, surgical treatment of penetrating head injuries. Over to you, Joe. Your mute button may be off. There we go.
Thank you. Let me see if I can share my screen properly. Would you let me know if you'd be able to see my slides?
Perfect. Perfect. Thank you so much.
Then we might need to swap here. Is it showing like the full screen?
Yes, perfect.
All right, then let's get started. Dr. Reisner, Dr. Rubiano, thank you so much for the opportunity. It's really an honor and a pleasure to be among celebrities in the world of neurosurgery. I appreciated the invite. I was thinking about how to keep you guys entertained on a Friday for at least 15 minutes. So then I thought maybe penetrating, like gunshot wounds, would be a good choice. So then, without further ado, let's try to keep up with time. Although the penetrating trauma is less frequent than the closed head injuries, it carries definitely a worse prognosis, and it impacts profoundly, not only on patients, but family members and the society. And by far, usually the most common mechanism of injury is gunshot wound, which and the extent of the injury typically depends on the caliber that's used, being military, more prone to more severe injuries, and also fragmented missiles are also involved with mortality. Talking about mortality, some CT findings can be really prognosticating. I'm gonna delve deeper into that in the slides to come. And in this initial part, the goal was to do a brief overview, what we typically do, and then start like an interesting case, and then talk about evidence. And so when a patient arrives to our Ryder Trauma Center, typically the investigation entails a brain scan. The choice that we need to make is if we have to perform some vascular study or not. And typically, depending on the trajectory or the suspicion of a large vessel injury, and then we do a CTA, or sometimes we send the patient for embolization before we take them to the OR. And as in any other trauma, I always tell my residents, don't forget the TLS, first airway, breathing, circulation, then you think about the neurologic status. And if the patients are not treated emergently with a craniectomy or craniotomy, usually we apply the multimodal monitoring tools like ICP monitoring, PPTO2, microdialysis, deep electrode, deep recording, and we try to mitigate the secondary injury. That's a big problem. So let's have a little more fun in the presentation. Let's see an interesting case that came to us a few months ago. This gentleman, 40 years old, was stabbed on the left eye and then was ran over by a car. He got to the emergency room in a pretty bad shape, where the GCS was 4, the cerebrated with brainstem reflex. He had bilateral pulmonary contusions. He got chest tubes and hemorrhagic shock, coagulopathic. So he was taken expeditiously to the OR by the trauma surgeons to do an X-lab. They found a liver laceration, which was packed. So he was really in a dangerous situation upon arrival. And from our standpoint, as you might have seen in the CT, he had an impressive injury. It's not going in. Yeah, a pretty impressive injury through the left eye, but he decompressed basically. So after the coagulopathy was corrected, I basically implanted an ICP monitor. The ICP was normal, so we deferred the surgical care once the systemic condition was stabilized. So then you can see maybe more details here. The roof of the left orbit was destroyed, and given the trajectory crossing the midline going to the opposite frontal lobe, I thought this guy must have a vascular injury. Although the initial CTA was negative, I couldn't believe it, like a long knife. And then I sent him for a DSA, and the angiography showed he indeed had 2 pseudoaneurysms that were coiled and secured before we intervened. So then, after about a week of systemic care, he fought sepsis, he fought complications. Then we decided that it was time to take him to the OR to do a orbital reconstruction and to treat. You see the artifact there from the embolization, and to treat the tissue injury. So nothing special. We took him for a bifrontal craniotomy, limited to the frontal bone, not expanding, because the goal was, like typically we do for anterior skull-based injury, we wanted to expose the base to try some sort of reconstruction, dural repair and debridement. So what we did was basically to take the flap out, and we split the bone flap in two, because as it's a penetrating trauma, delayed care after sepsis, we consider the chance of local infection was high, so we wanted to use as less foreign bodies as possible. Then, yes, navigation was also used to be sure that we did a completely debridement, going up to the floor of the left orbital compartment. And then here you can see some images where we applied this construct to secure the bone flap and to use the pericranium, as we typically do, for reconstructing, protecting not only the floor, but also the dural. I had a video about it, but we can jump off. So we could go only so far with the reconstruction, and then the second part, the most posterior aspect of the defect, was repaired using an endonasal approach with a nasal septal flap, which was very successful. No more CSF leaks were observed. But of course, life is not easy, doesn't make it easy to us neurosurgeons. What he had was, of course, a brain abscess. Yeah. And then, as you can see here, the contrast enhancement, we treated initially with broad coverage antibiotics. It didn't, the abscess continued to increase after a couple of weeks. And then I decided to go stereotactic with a frameless abscess drainage. And after more than 3 months, this patient that arrived in GCS4 with polytrauma survived, and it had a good functional outcome. He was speaking to us. He lost the eye naturally, but he was speaking to us, and he was glad after the so much care. So this is a typical example of maybe an extended example of a surgical case. I thought it was interesting to show how many modalities can be intricated in the care. But let's take a step back before I continue. Do we need to go so far? Usually not, absolutely not. I think it's much more meaningful to think always about, should we go surgical, should we keep medical treatment, and shouldn't we tailor the approaches? So, like for instance, here a typical, let me just minimize the volume here. I don't want to hear my voice. So this case, for example, classical indications for surgical treatment is like when the fragment is still protruding, or you have extensive hematomas, or pseudoaneurysms can be repaired open. Here you see, I think it's a 45 ACP because it's much larger than the usual 9 mil that we see here. So Bernard and I, our fellow, my dear fellow and friend, personal friend, we removed this fragment, and we removed the deep fragments that were also in the parenchyma. But of course, most of the literature, I don't know how my films are not going, but anyway, typically the literature that we have, that we had in the beginning about how to treat those patients came from the Vietnam War. So they would go pretty extensively doing deep debridements and chasing every fragment. But these days, of course, it changed, the strategy changed. And for instance, this guy was shot 16 times 3 days ago, the transfer, when he came from, when he was transferred. And we just went for the most superficial fragments that followed that. But then on the other hand, we have the conservative management. So like this typical example from a penetrating trauma from Sir Harlow in the last century. They basically removed the foreign object, they dressed, they bled him, the abscess drained him spontaneously. So, and and maybe tailoring the approach is what we should do, and we should even tailor the surgical approach. And that's the, I believe, the most important part of the talk, which will come in the end. For instance, it's important to have some sort of understanding where are we going with a patient when we're trying to select the best way to treat. Some prognostication is important to my view, especially to see if this patient is a salvageable one. So this classic paper from the group in California, talking about the zona fatalis, I believe everybody knows this, but it's good to show about it. The zona fatalis was described to be about 4 centimeters above the dorsum saline, meaning if you have a through and through gunshot wound that crosses this area, it's typically 100% of fatality. As well, if you have the trem track or trem tracking, this signal with this pattern of bleeding crossing the hemispheres is also a sign of mortality, and the presence of diabetes insipidus and a bad GCS of 4 or less upon arrival. Those are typically associated with a high mortality or absolute mortality. And this group, the Baylor group from Houston, Texas, they were looking at the other spectrum, what to expect if you like which patients would survive or would maybe have a meaningful neurological recovery. So they came up with a score in which if you're over 35 years old, most of us are not there. So we better not get shot in the head. So if we're older than 35 years old, the GCS is below 4, non-reactive pupils or posterior fossa or bihemispheric injuries, they're associated with a worse outcome. So you can assign points and have a score that will show you an absolute high mortality if you have 3 or more points, and proportionally, the lower points you have, the better your functional outcome. Also, this group from Melbourne, they show that naturally, if you have a proper initial care, this can help you to survive and to do well after a gunshot wound to the head, like urgent resuscitation, correction of coagulopathy, early decompression in the cases they are selected to, will help you. And also the trend tracking was observed to be a sign of bad prognosis, like high mortality, and they typically don't recommend to go surgical if your GCS is 4, 5 or less, and if you have fixed dilated people. Everything so far very meaningful. Some groups even try to come up with computerized predictor models, being the CT-based Helsing score, the best one to predict mortality, and the Marshall CT score, the best one to predict unfavorable neurological outcome. But in fact, this doesn't change much in the prognosis if you compare to the clinical factors. So we typically don't use them to decide. So we have an idea when we should go medical, potentially the non-survivable patients, and when to go surgical. But when to be less aggressive. And is there a role for a bedside treatment for a gunshot wound? And we do believe there is. The initial articles about it, I could select this paper from 2001 from the journal Neuro-Trauma, saying that if you have a small entrance and the patients don't have significant intracranial findings, you could do a bedside thorough washout, close the entry point, and then you'd have a good outcome. But we wanted the literature to look more about it. We couldn't find initially, so we decided to do a systematic review about the topic, and then we published like an extensive review in which we selected over 7,000 papers according to the PRISMA protocol. We selected 17 of those, looking into neurologic outcome, mortality, infection, and seizure, comparing surgical treatment, the classic craniectomy or craniotomy, and comparing with the bedside washout. Okay, it's important to mention that this was on civilian cranial gunshot. It doesn't mean we didn't have military missiles involved, but in a civilian environment, like in the city, not in the jungle or in other places where most of the older literature comes from. So this impacts, of course, infection and other things. So what we found regarding the risk of, regarding the neurologic outcome. So basically, in all aspects, the literature, the quality of evidence was very low. And regarding the neurological outcome, if the patients have a reasonable exam, like typically the GCS is above 9, we didn't find significant differences in the literature comparing both techniques. So this should, if you have a good exam and you don't have any impressive intracranial finding, you could think about a bedside washout and simple closure. Regarding mortality, if the GCS was above 6, basically no important difference. Okay. Regarding infection, same thing. So those are those, and also seizures. So if you think about going open surgical or going to bedside, it's not because you want to reduce infection, reduce seizure or chronic post-traumatic epilepsy, or to improve neurologic outcome. Basically, the evidence, it doesn't support. You would go for an open surgery if you have impressive findings or the locations. So to try to stratify this better, we did a second study. And before I move on to that and finalize the presentation, the fact of having retained foreign body fragments was not important to development of seizure and also infection. It makes sense because typically deep fragments are the ones that are further from the cortex should not be so epileptogenic as the cortical ones. That's one, right? And also the gunshot wounds, they are like firearms injuries. The fragments, they come very hot, so basically sterile. It's different from other sort of penetrating injuries like stab wounds or maybe BB guns or pressure, in which they are not as sterile. So that would make sense in terms of the infection rate and epileptogenesis. So to sum up and finalize, the last paper I'm going to present you is this paper we published at the Journal of Neurosurgery, in which we wanted to express our self-experience on the topic. So we selected, we basically don't select, we just collected based on our trauma registry, the last 67 patients that were treated, being 50 with regular surgery and 17 with simple wound closure, like bedside washout and closure, in which we saw the age was, we matched the age, clinical score, neurologic exam, and then we saw that, well, before that, typical examples. So, for example, this patient with a tangential gunshot wound, although it's not deep, but you see the extent, the extent of the injury. So more extensive with more impressive cranial findings, we typically take to the OR, and more local and superficial, we don't. And we came up with an algorithm, like a proposal, a suggestion. And especially this could be useful for for colleagues in a more remote location, centers that don't have neurosurgery available. So you can do good care in selected cases without major efforts or infrastructure. So first you'd look into the clinical condition. If you deem the patient has a futile expectation, where the futile treatment is deemed like non-survivable injuries, of course, you're not going to go to the OR, you can do it bedside. But the salvageable patients, based on the slide we saw before, if you have a significant hematoma, significant mass effect, refractory intracranial pressure, high risk of infection, based on the location, for example, close to the frontal sinus, like open cavities or gross contamination, or a delayed transfer like we had, and an acceptable risk benefit, like you're not like very close to a major durosinus or a very eloquent area. So then you can choose, you can reassign, and based on those criteria, if you go surgical, open surgical, or with a bedside treatment. So, but before we finish, I'd like to thank you again for the invite, and to again announce our fellowship. We're a clinical fellowship in Neuro-Trauma here in Miami. We have a very extensive center. This building, as you can see, the Neuro-Trauma Center, the 4-story building dedicated for trauma. just it's in the Jackson complex within the medical campus, where we have like 25 trauma ICU beds, 27 neuro-ICU beds, 6 trauma dedicated ORs. It's the only center for the military medics to be trained before being deployed in combat or in missions. And of course, international applicants are very welcome. Thank you so much again.
Well, Joe, thank you for that excellent talk. And I think you're too modest to add another attribute of the building that you said is just incredibly well known and well renowned. And thank you for all that you do and all the people that you train at your Trauma Institute. Thank you.
Thank you.
Any questions from the panel for Joe? Comments? I will just mention, Joe, it's a sad statement, but there's actually a scoring system for pediatric gunshot wounds to the head. It is the St. Louis scoring system. I'm not sure if you're familiar with it, but unfortunately, it's something that we are seeing quite frequently.
Also sad, we recently published a review on the topic, like with our experience in gunshot wound in kids. Yeah.
Really? Where was that published, Joe? I did not come across that.
Yeah. In the Red Journal. In the
Red Journal.
I can send you.
Yeah, please. Thank you. Very good. We're actually looking at our series at the moment, so I'd be interested to read that. Thank you. Andres, Nessa, any questions from you all? I think that, Andres, thank you so much for answering the questions in the chat box. Quick last question for you, Joe, from the chat box. Seizure prophylaxis, any quick comment on that?
That's an excellent question. So although intuitively you keep the patients on long term, but we follow the BTF guidelines in which we just see evidence, just could find evidence for the early seizure prophylaxis, meaning the first week we give any seizure medication, typically levetiracetam or Vimpat, and then we watch. If the patient ever ceases, then we resume, and then we keep for an extended period, and then we will be guided by electrophysiologic findings. But otherwise, we don't keep them on long term, as we would think would be.
Thank you.
I don't know if in kids you do the same thing.
Pretty much, yes. Pretty much the same.
Okay.
Thank you, Joe.
Yes,
Thank you very
I
much.
just want to add, Professor Reisner, say again thanks to Joe for this great presentation. And just to update the audience that we are in the process of updating the penetrating TBI guidelines of the Brain Trauma Foundation. And we are actually working into many of these articles that have been published recently. We need to remember that the last set of guidelines were for 2001. So we are now reviewing near to 300 or more new papers that are being discussed for this important topic. So I just share in the question and answer box the rationale and methodology for the updating process. So if someone have articles that you can consider that can be taken into consideration for this review, we are very welcome to receive suggestions. So just to update about that.
Thank you for that. Thank you for that, Andres. I'd like to introduce you to a very honored guest, Mario Janal from the United Kingdom, who has been very patient. I know he has a full day with vivas and oral exams that he's given. And Mario's had a long interest in traumatic brain injury. He wrote an excellent paper on the management of agitation following traumatic brain injury just before COVID in 2018, I believe it was. Mario is going to speak to us about cranial reconstruction following DC and pitfalls and how we should do it. So with that, welcome, Mario, and we are honored to have you.
Thank you so much. I hope you can see my screen.
There we go.
Wonderful. Yeah, I think we are set up.
Not full slide yet, Mario.
It appears very well on my computer.
There we go.
Can you see it now?
Yes, now we can see it. Thank you.
Wonderful. So thank you for the introduction and for this kind invitation. I'm the head of adult neurotrauma service in Oxford, and the topic of this talk would be really surgical planning and pitfall avoidance in cranioplasty. As you know, the trends in number of cranioplasty has increased over time, and obviously we have in the last 10 years only a five-fold increase in the number of cranioplasty procedures performed all over the world. Why this? Obviously, because we had also an increase in the number of decompressive craniectomies, supported very well by the results from the Rescue ICP trial, which demonstrated an increase in survival rate following the compressive craniectomy, and the follow-up to that, to the analysis of their database, demonstrating that patients continue to improve even after 12 months from the compressive craniectomy. Obviously, once we have a calvarial defect, the next step will be considering patient for cranioplasty. But there are a lot of debates surrounding the ideal pathway for cranioplasty. In fact, I'm bringing to you the results from the consensus statement on post-traumatic cranioplasty. This was published by Iaccarino et al. In Acta Neurochirurgica. And as you can see, the only two statements where there was 100% agreement was were obviously regarding the indication to consider cranioplasty only in the absence of medical comorbidities and when patient was able to provide the full consent. And the other aspect regards the indication for cranioplasty, which obviously includes the anatomical reconstruction and protection of the brain, and restoration of the closed box, and obviously the promotion of functional and psychological recovery. In cranioplasty have been performed basically for many centuries. For those interested in history of medicine, there is a very nice paper from Verano and Andrishko on the experience on cranioplasty that and reconstruction of calvarial defect from ancient Peru, and I certainly recommend that paper. However, obviously, in the last 20 years, we have witnessed a lot of improvement. At the moment, there are classification for timing of cranioplasty, and we consider ultra-early cranioplasty all those that are performed within 4 weeks from the decompressive craniectomy, early cranioplasty within 3 months, and late cranioplasty after 3 months. I'm going to show you this forest plot is from one of my paper on neurosurgery in 2018. And as you can see, basically, the forest plot indicates that the patient tends to do better if the cranioplasty is performed within 3 months. However, the funnel plot demonstrated there is a lot of heterogeneity in the studies considered, and therefore we need to take this with a grain of salt. Also, there are multiple materials that we can consider for cranioplasty. The most intuitive one is autologous bone. However, there are a lot of synthetic materials that can be considered for custom-made cranioplasties. And really, our belief in Oxford is that there is no ideal material. None of those options is far superior to the others. And this is the reason why in my own practice, I really like to consider every patient needs and try to use the cranioplasty that meet those needs the best. And regarding autologous bone, obviously we know that this is possibly the cheapest and easiest solution. However, one of the big concerns is where do we store the bone flap. There is a nice article from Ishfan in Iran, was published in 2021 in Journal of Clinical Neurosurgery, and basically it provided the results of a randomized controlled trial on the use of cryopreservation versus subcutaneous pocket. And this was indicating superiority of subcutaneous pocket. However, obviously, this solution that I'm presenting you on this slide is not ideal. The patient arrived to our attention several months following the initial trauma, and obviously it took a lot of consideration, both pre-operative and intraoperative, to make sure it could have a good cosmetic outcome without incurring into intraoperative complication. Eventually, I was obliged to drill down the entire autologous bone because it was not possible to remove it. My practice is, as I say, neurotrauma and complex spine surgery. I think it's the first time that my scrub nurse had seen me with a chisel trying to lift that bone flap. It was not possible, not safe. So eventually I was obliged to consider drilling with a match head perforator. Other issues with autologous bone is obviously resorption. This is a case that was operated 5 years ago, came to our attention with extensive resorption. This led to fracture of many of the titanium plates used to secure the flap. And as you can see, intraoperatively, it was impossible to really lift safely the residual aisle of autologous bone. Again, the strategy here was trying to reduce the mass effect. The drill were safe, and then consider the patient for custom-made titanium cranioplasty, which is obviously the best solution for onlay reconstruction. Also, for the sake of scientific discussion, I'm presenting here the OLU bone resorption score. Is something that I use routinely in clinical practice when I have to grade patient before surgery. This really helped me understanding the severity of the bone resorption and how to handle better the situation. As you can see, there is a grade 1, grade 2, and grade 3, with grade 3 showing only very isolated aisle of bone. Removing that bone obviously is extremely difficult because it's extremely adherent to the pseudodura. So I think that the success in cranioplasty is not determined in the short term, but in the long run, and those cases confirms this statement. As you can see here, we have 2 examples of titanium mesh that were implanted, the first one 10 years ago and the second 15 years ago. And interestingly enough, none of those patients came to our attention with raised inflammatory markers or signs of sepsis. So this indicates that most likely the underlying dura was still providing a good protection to the central nervous system. What do we do in Oxford? Well, I'm lucky enough to have a very close collaboration with my colleagues from the craniofacial unit. The cranioplasty pathway that we have designed is basically a mixed neurosurgical and plastic surgery cranioplasty, and this really follows on examples that have been provided by other teams elsewhere. I can think the Vanderbilt University team in Nashville, who have published their experience on a plastic and neurosurgery pathway in 2002 on World Neurosurgery. In my hands, I tried to obtain a CT scan for design of the custom-made cranioplasty as close as possible to the surgical intervention. And we have a very clear standard operating procedure to make sure we reduce as much as possible all the risks. And so let's move to the pitfall avoidance stage. First of all, Prior to cranioplasty, we need to optimize nutrition, normalize plasma albumin, and make sure when patient has a good glycemic control, if possible, stop smoking, stop steroids, and important to consider also timing of radiotherapy or management of infective sinuses before proceeding with a safe cranioplasty. Consenting process, I always describe those steps because I feel they are one related to the other. Obviously, risk of bleeding, it can occur intraoperatively or postoperatively in various intracranial compartments, subgaleal, extradural, or subdural. And these can facilitate, if left untreated, the creation of either granuloma or even a wound breakdown, particularly if there is skin ischemia or decubitus, perhaps related to poor handling of the trauma flap and lack of good blood supply to it. And this opens the door to surgical site infection, which can be superficial or deep, primary or secondary, early or late, depending on possible contamination at time of surgery, or late, obviously, if we have contamination following a wound dehiscence. When I consent patient, I always discuss also possible causes for implant failure, including displacement and fracture. As you can see here, patient had a very severe displacement of the cranioplasty due to bulging of the brain, and this patient was referred from another unit. Eventually, our root cause analysis indicated that potentially should have been considered for a CSF diversion earlier. In terms of cranioplasty setup, I always like to have a preoperative plan if we need to do skin advancement or skin graft. We consider basically a wide scalp exposure, pretty much like in craniofacial procedure. We tend to shave the scalp. We tend to do when we opt for minimal shaving over the previous wound, we certainly proceed with head wash before prepping, and we try to avoid all tension points from pins and drapes. Even the raising of the scalp is something that needs to be performed with very accurate technique. We like to expose the bone first, the edges of the previous decompressive craniectomy, use a monopolar fine point diathermy as opposed to a blade. Usually with a low voltage, there is minimal risk for damaging either the pseudodura or the skin flap, and actually is the best way for us to maintain a bloodless surgical site, as I can show you in this image. Usually we like to have a surgical site that is nice and clean before we start the stage of implanting the custom-made cranioplasty. And even the implant of the cranioplasty needs to be performed in obviously in a septic measure. So we like to change our gloves. We like to either clean the cranioplasty, either clean the surgical site with a mix of iodine and saline solution. If we are using a porous cranioplasty, we like to soak it on gentamicin before implant, so that it can basically provide a release of antibiotics in the surgical site and reduce the risk of surgical site infection. Here are a few examples. We use, as I say, different materials. Very nice bifrontal peak cranioplasty. As you can see here, we have the two overlying pieces of the cranioplasty with which are secured with 1.5 diameter screws. and provides a very good protection without any issue with the forehead. This is another bifrontal cranioplasty, another plastic material, acrylic. As you can see here, again, the use of two pieces for the cranioplasty with the fixation points left more lateral in this case in order to provide the best cosmetic result. Very large unilateral decompressive craniectomy, which was reconstructed through a large titanium 3D printed titanium cranioplasty. And as you can see here, huge work with our plastic team to make sure that we had a viable skin flap and satisfactory closure. Another example of hybrid cranioplasty, in this case, bilateral cranioplasty, we use an hybrid construct with a titanium mesh and calcium phosphate, which is known to increase osteointegration. How do we proceed after the implant of the cranioplasty? Obviously, the intervention is not over, as the the anesthesia or the scrub team may think. We need to make sure that we have a good closure, and this comes through excision of the margin of the wound to make sure that we have a good approximation of the margins. We might consider techniques like radial gallial scoring, as we do in pediatrics procedure. We excise scars from the healthy scalp, as I say. We make sure that we have a good approximation. So this approximation has to be performed with minimal tension and with a clean wound bed. And at times our closure might be very complex, like in those cases. So you can see here two flap advancements without the need for any graft. A closure, even the closure is important. It's not something that we can leave to our junior doctors. So we like to have the closure done by experienced surgeons. Deep sutures as to take all the tension, whereas the subcutaneous ones and the skin ones are for cosmetic results. So excellent approximation and good cosmetic outcome. This is an example. We like to use resorbable sutures, and we always perform another head wash at the end of the procedure, and we apply some chloramphenicol ointment on the wound to provide another protection from external agents, including water or bacteria. Take-home message for this talk. So I think pitfall avoidance comes from a good understanding of the complexity that the cranioplasty pathway might have, both in terms of patient referrals, so the problem of timing of cranioplasty, but also the appropriate collaboration with specialties, other specialties, including, as in our case, plastic surgery. So the take-home message is really that soft tissue and fixation points are critical aspects and should be, and the handling of those issues should be very carefully thought after by the operating team. I want to say that coming up, there will be some results from the consensus conference led by Professor Franco Servadei and Corrado Iaccarino on the cranial reconstruction in patients with post-traumatic hydrocephalus, and this is the reason why I didn't touch on this topic. However, there are some other resources that the audience can certainly find on the internet, including some free lecture from the Codman Academy. And with this, I conclude my talk, and thank you very much, Andrew, again, for inviting me.
Mario, thank you so much for an excellent talk. You gave us much to think about, and we really appreciate you sharing your experience with us. Any comments from the panel before we move on to the next talk, which is also on decompressive craniectomies?
Yes, Professor.
Go ahead, Gustavo.
Yes, great talk. I would ask about if you have a big hemicraniectomy, what kind of material and what kind of technique, hand-free, or you use 3D dimensional performing the prosthesis?
Yes, so basically we always go for custom-made prosthesis. Again, the type of the material depends on the needs of the patient. For instance, if we are doing a reconstruction for a patient with MCA stroke, I think a titanium cranioplasty can be good enough. In the literature, we can see that the various registries, we have collaborated to the UK and Ireland one published by one of our trainee, Daniel Fontaine, in neurosurgery in 2021, was indicating that, for instance, in the UK, titanium is the material of choice. However, there are regional preferences. In France, for instance, the material of choice seems to be a ceramic, and similarly in Italy we have porous hydroxyapatite as the favorite material for cranioplasty. So I think we have to consider regional preferences, surgeons' preferences, but also patient indication. As I say, MCA stroke, titanium is very good. It is less appropriate if we're I tend to prefer plastic cranioplasties in patients who might require radiotherapy or stereotactic radiosurgery afterwards. And I always try to involve patients as much as possible in the decision-making process. So I really come to my outpatient clinic with some 3D replicas of cranioplasties and show them the pros and cons. So they are involved in the decision-making with me.
Thank you, Mario. We have a question from Professor Darmul. He's raised his hand. If you could unmute yourself. Professor El-Ghandour, I don't know if it's possible to ask him to unmute himself.
Mahdi Darmul, you raised your hand. Would you please unmute yourself
There we go.
and contribute to discussion? Mahdi Darmul. And another one raising hand, Ganzouri. Would you please, if you like to contribute to discussion, or you raised your hand by mistake?
Ganzouri, do you want to say anything? While we're waiting, I don't know if the article that you quoted on the consensus statement on DC was written by, first author was Corrado Icorino. I know Dr. Rubiano was a co-author on that, and maybe Dr. Rubiano can comment either now or after the next talk on his extensive experience.
Thank you, Professor Reisner. No, I think the presentation from Professor Mario was really great. I think many of the considerations that have been discussed are in place. And definitely what we need to see is to have more studies, especially in areas where not all the materials are available. As Professor Mario mentioned, will be very important to know more about what are the current practices in areas like Sub-Saharan Africa, even Latin America and Southeast Asia, in order to understand a little bit more many of the complications that already have been described from areas that have most of the materials available. So definitely, I think we are living in an interesting point right now where many different materials are available according to each one of the conditions. And the idea is to promote more at least the observational studies that can be done in order to understand the impact of the current practices.
Thank you. Thank you very much, Dr. Rubiano. And with that, if you don't mind, we'll move on to the last of the three talkers of the session. And we are really honored to have a outstanding speaker from Brazil yet again, Rodrigo Faleiro. Rodrigo's got an extensive clinical experience. He's published a lot. I see especially 2022 was a very productive year for you. He published an excellent article with the Global Neurotrauma Outcome Study in the Lancet, nonetheless. Co-authors were all the luminaries in TBI. including Andres Rubiano and Peter Hutchinson. And so thank you, Rodrigo, for your contribution. If I could just say that I was interested to read that you had an interest and also co-authored an article on the renin-angiotensin system in TBI. Maybe you could give a talk on that one day, but for now, we're going to hear your experience on decompressive craniectomy. Over to you, Rodrigo. Thank you so much for honoring us with your presence.
Okay, let me share my presentation. And that's okay for you? Okay. Okay, I would like to thank the World Federation and Planck invitation to speak about the compressive craniectomy. I would like to address here how we manage the severe traumatic brain injury in Brazil. I represent an important trauma center that we have, a public hospital named the John 23 Hospital. And I have no conflict of interest in this presentation. Neurotrauma is a very important topic for us here in Brazil. And that's because 17 of the 50 most violent cities in the world are situated in my country, accounting for thousands of violent deaths each year. If we take a look at the Bosnian War, there were 7,000 deaths. And almost 60,000 American soldiers died at the Vietnam War, a war that lasted 7 years. So if we take a look at Brazil, it's like if we have one Vietnam War each year with more than 60,000 intentional deaths each year. And if we add the traffic-related deaths, there are more 47,000 deaths. So what I'm trying to say here is that in Brazil, we have more than 100,000 preventable deaths each year. This is our trauma hospital. It is named John 23 after the Pope, and it is a central reference for burned patients and trauma patients that came all over the Minas Gerais states. Minas Gerais has an area similar to France with 21 million current population. It is a huge hospital with more than 500 trauma-dedicated beds, more than 100 intensive care unit beds. So some number from 2015, we had 1,862 TBI admissions, 30 severe TBI among, and the general mortality in the severe TBI is around 34%. Well, I would like to begin my presentation with 3 important statements. The first one is that elevated intracranial pressure is a single and independent factor to poor outcome. There are so many papers showing this, and this is just one interest paper by Geoffrey T. Manley, and they demonstrated the relationship of the dose of intracranial hypertension to outcome. The greater the area above 20 millimeters of mercury, the worse the prognosis is. So the second statement is very clear, because if intracranial hypertension is associated with poor prognosis, it should not be tolerated. Intracranial hypertension must receive early and aggressive treatment, no matter if this treatment will be medically or surgically. Intracranial hypertension can be tolerated. And there are many tools we can use to lower intracranial pressure. And the compressive craniectomy is just another tool, and very effective tool to decrease intracranial hypertension. As you can see here in DECRA study, the compressive craniectomy is very effective in lowering intracranial pressure when compared to standard care of treatment. I'm not saying here that the compressive craniectomy is associated with good prognosis. I'm just saying that the compressive craniectomy is an efficient tool to decrease intracranial hypertension. And intracranial hypertension is associated with poor outcome. So we all read about the standard treatment of intracranial hypertension, and the compressive craniectomy is often regarded as a last resource in the treatment of intracranial pressure. What I'm trying to show in this presentation is that the compressive craniectomy can be used in the very beginning of this stepwise treatment in some patients. And this is a very important statement. For the medical treatment to be effective, mannitol, hypertonic saline, the cerebrovascular autoregulation must be intact, otherwise medical treatment would fail. And the bad news is that almost 70% of patients of severe TBI will lost autoregulation. So we can see why the compressive craniectomy is so necessitated, so needed, because there is a lot of medical treatment failure in the brain swelling patient. So the loss of the cerebral vascular autoregulation is called brain swelling. So it is very important to say that the compressive craniectomy is a surgical procedure indicated for the treatment of brain swelling. For me, the best indication of the compressive craniectomy is for brain swelling. So we must find how this brain swelling patient. So the best way for me to find the brain swelling patient is first to classify our severe traumatic brain injury patient according to Marshall CT scan classification. And the Marshall 1 and Marshall 2, those are the diffuse axonal injury patients. And Marshall 3 and Marshall 4, besides diffuse axonal injury, they also have some autoregulation impairment. Marshall 3 has bilateral brain swelling, and Marshall 4 has unilateral brain swelling. So those are the potential candidates to receive the compressive craniectomy. And it is very, very important to classify what kind of the compressive procedure are we applying, because there are some patients that go through ICU, receive intracranial monitoring, and on day 2, day 3, day 4, they became medically refractory. So the compressive craniectomy is called secondary decompressive craniectomy. And there are other patients that go through OR to have an acute subdural hematoma evacuation, and we can have massive swelling and the bone is left out. So in this case, it is called primary decompressive craniectomy. So it's very important to specify what kind of decompressive are we applying, primary or secondary decompressive craniectomy. And Marshall 3 is the potential candidate to receive secondary DC, and Marshall 4, for me, is the potential candidate to receive primary DC. And when we study the DECRA and the rescue ICP, they are studying the role of secondary DC in the traumatic brain injury patient. And the acute subdural hematoma rescue, they are studying the primary DC on the role of acute subdural hematoma evacuation. So a common question is, when is early DC really an early DC? So it totally depends of what kind of patients are we dealing. They are Marshall 3 or Marshall 4 patients. So here is adequate primary decompressive craniectomy. And here we can see a secondary decompressive craniectomy. This is our trauma unity where the polytrauma patient receives the standard of care of advanced trauma life support treatment protocol. And as you can see here, we have a compilation of Brain Trauma Foundation guidelines regarding initial management, Marshall CT scan classification, and the specialized neuro treatment. So the emergencies, the neurosurgeon, they can combine the Marshall CT scan classification with the Glasgow Coma score and find the best treatment for that patient, according to the Brain Trauma Foundation guidelines. For us, in our hospital, the patient with Marshall 1 to 3, they must go to intensive care unit and receive the standard of care treatment of intracranial hypertension, general measures and specific clinical measures. So this is an example. A 9-year-old male, traffic accident, severe TBI. We can see here a Marshall 3 CT scan, and ICP was around 30 millimeters of mercury, already refractory to medical treatment. So what would you do in this situation? Fortunately, we were having important visitors at that time. And Walter and Randall Chestnut would choose, at that time, 2014, would choose barbiturates, and Walter Vaideta would choose the compressive craniectomy. So it's very interesting how two experts can have two different opinions. So we don't have a level 1 of evidence in this topic yet. And for us here in our hospital, when we have a patient with acute subdural hematoma, a high energy cinetic trauma, midline shift more than 5 millimeters, and Zunkeller index more than 2 millimeters, this patient is usually with dilated pupils unilaterally. They must go to operating room and have acute subdural hematoma evacuated, and the bone is left out. This is a primary decompressive craniectomy. So an example, 33-year-old male, high-speed traffic accident, GCS of 5, and with left unreactive pupil. So we can see here this CT scan, we can see here a brain contusion, a laceration, subarachnoid hemorrhage, and a midline shift of 10 millimeters. So this is a case of Marshall 4 patient. So our neurosurgeon on call performed a primary unilateral decompressive craniectomy. And as we can see here, there is a return to the midline, to the center. It's a good result. But if we take a close look here, we can see that much temporal bone was left behind. And it is very important to remove this temporal bone in order to decompress the midbrain. So we must know how to indicate the compressive craniectomy, but it's very important to perform the procedure correctly. The compressive craniectomy is a simple and effective procedure, but it has its own complications which can negatively affect the prognosis. For me, DC is not the end, it's just the beginning. It's like if we are just opening the Pandora box, and now the troubles, the hydrodynamic problems will come after us. According to Juan Cerrutillo, 1 of every 10 patients undergoing DC may suffer a complication and necessitate additional medical or neurosurgical intervention. So there is a lot of complication. It can be groups in 3 major types: hemorrhagic complications, infectious, and disturbance of CSF compartment. This was my master's degree paper. So in 2008, I studied prognostic factors and complications in 89 patients. As you can see here, 92% were Marshall 4. 32% of patients has one or both unreactive pupils. And in these patients, if we look at the literature, Marshall 4 patient has around 56% of mortality. So in our study, it's the same, 54% of mortality in this group of patients, and 25% achieved a good outcome. And we were able to correlate the GCS upon admission with prognosis. And we found unique hydrodynamic complications after the compressive craniectomy, hydrocephalus in 8% and unilateral bilateral subdural effusion in 11%. And chronically, they may have sinking flap syndrome. But before blaming just the DC for these complications, we must check if the correct surgical technique has been applied. Over the time, now we are choosing the Kemp incision over Becker incision, the trauma flap, because it is very common to have this kind of scalp necrosis. In order to achieve a large flap, we can compromise the occipital artery to the flap. So I prefer actually the Kemp incision. The compressive must be wide enough, but more important is to have flush with temporal fossa. The temporal bone must be totally removed in order to decompress the midbrain. For me, it's very important to perform an imagic duroplasty with 4-0 Prolene because of the hydrodynamic complications. So it is very important to have a watertight closure in order to prevent the CSF fistula. And we have a public hospital and the bone is restored in the para-umbilical area. We must pay attention to the infection. This is another study for our group showing that in 45 patients receiving cranioplasty in this patient with large hemicranial bone defects, there were 24% of infections. But the most common cause of infection in our study was the low hemoglobin level. So it was correlated with high index of infection, the lower the hemoglobin level is. It is very known, this concept, military concept of neurological damage control. This is an important paper of 2010 of Randy Bell and Rocco Amonda, explaining how to perform a good decompressive craniectomy. Here you can see the Kemp incision, the wide craniectomy, and they studied that in the war, Iran-Iraq war. So should we apply this military concept of neurological damage control to the civilian population, and when? Whenever we have a large number of patients in a situation of limited resources, that unfortunately sometimes is our reality here in Brazil. So I'm glad to participate in this study with Andreas Rubiano, the evolving concept of damage control in neurotrauma, application of military protocols in civilian settings with limited resources. So here we describe the various skin incisions, the various types of decompression, bone decompression, duroplasty, and reconstruction. Concluding, for us, the severe TBI, Marshall 1, Marshall 2, and Marshall 3 must go to ICU and have ICP monitoring. If it becomes medically refractory, secondary TC is indicated. And the Marshall 4 plus acute subdural hematoma, we use the Zunkelli index, that is the correlation between the hematoma with the midline shift. If the difference is more than 2 millimeters, there is unilateral swelling. So we use primary DC. And if the index is less than 2 millimeters, the bone is put back in the cranium. I'd like to conclude that the compressive craniectomy is a very effective tool in decreasing intracranial hypertension. Complications are common, but amenable to treatment, and most of it preventable. The functional outcome of this is totally related to the successful management of these common complications. This is my city. My city is called Belo Horizonte. There is a wonderful horizon. It's easy to see that. And this is a Randy Dillon picture of the female soldier with the compressive craniectomy. Thank you very much for your attention.
Thank you, Rodrigo. That was an outstanding talk, and wow, so much work has been done in your papers that you put in, and we are honored that you shared your wealth of information with us. You know, Dr. Rubiano introduced me to many things. The most recent one was the whole concept of compartment syndrome, which just sort of a light went off in my eyes. You know, why don't we think of the brain like a compartment syndrome, like other parts of the body? And I just mentioned that if Andres would like to comment further, he'd be welcome. But as much work has been done, but I think we can all agree that there's so much more to be done. And certainly don't have all the answers. A quick question for you, Rodrigo. Do you do all your decompressive craniectomies immediately, or do you ever do them in a delayed fashion, or what is your sort of algorithm? I got a little distracted hearing your plan.
Yeah, usually when we are dealing with a Marshall 4 patient with unilateral dilated pupil, it is done immediately. They go to a operating room, receive the decompressive surgery, and ICP to ICU. So it is immediately. But in the Marshall 3, is only when it becomes refractory to medical treatment, as soon as possible, right? As soon as the medical refractory is determined.
Thank you. Andres, would you like to comment on anything?
Thank you, Professor Reiser. No, I think according to some of the questions that have been put in the question and answer box, is definitely, there are many practices out there that need to be like more studied, and definitely, as Rodrigo presents, the damage control approach is very focused on areas that do not have too much monitoring in place. And definitely, as much monitoring is in place, you can take a decision-making point later. As Rodrigo mentioned, if the patient is very deteriorated and there are martial indications for urgent management, definitely needs to be do it as early as possible. And the other issue is that there have been some questions regarding contusionectomy or partial lobectomies in this type of patients. I think the current trend is to do less and less lobectomies in these trauma patients, but I think it will be interesting to have some talks about this. And I invite Rodrigo and Joe and all the other speakers to type into the questions that have been posted in the question and answer box for many of the people of the audience. Thank you.
Thank you, Andres. And I'd like to conclude this session by thanking our three speakers, Joe, Mari, and Rodrigo, for just outstanding talks. And with that, it's really with great pleasure that I hand over to the third session to my friend and a very respected voice in neurotrauma from Spain, Professor Alfonso Lagares. We are so glad to have you with us, Alfonso. Over to you.
Thank you, Andrew. Thank you. Thank you so much for inviting me to moderate this session. I think this last session will be also very interesting for the audience. We will have three expert speakers on the application of techniques and treatments to improve patients' outcomes in areas with limited resources, where physicians have to deal with situations without many technological advances that are described in our journals and that are present in high-income countries. The first speaker will be Robson Amorim from Brazil. He has published a number of papers on neurotrauma care, focusing on decompressive craniectomy and cranioplasty, and also on outcome prediction in low and middle income countries, and also on the application of trauma protocols in areas with limited resources. So please, Robson, could you begin with your talk about neurotrauma in the Amazonian region, doing more with less?
Hello, Alfonso. Thank you for presenting me. I'd like to thank you, Andres, Dr. Reisner, for the invitation. And I would like to salute all the panelists and the audience. So I'm going to talk about neurotrauma in the Amazonian region. I'm Robson Amorim from University of Amazonas and University of São Paulo. I do not have any conflict of interest to declare. Just for you to know that the South America here We have in green the Amazon forest. Look, that it's very huge, and it covers many countries, and most of the forest is located in Brazil. And just for comparison, we can put all the Western Europe inside the Brazilian Amazon for you to know the extension of this. And in Brazil, the largest state is Amazonas. That's really in the middle of this great forest. It's like Alaska for the Americans. And here in green is Manaus, okay, a city with 2 million inhabitants, okay. And as you can see in this map, here are in red lines and black lines are our roads in Brazil. And look that we almost do not have any roads here. This road here, I don't know if you can see the arrow, but this road here actually do not work. So here, if you can see. So our roads actually are our rivers. Like you can see the extension of the rivers here in the Amazon. And it's very far from a place to another. For example, it takes 5 days and 6 hours moving from a city here next to Colombia to this red spot that is Manaus, through the river by ferry. So just for stress the issues that we have here. Here is the hospital where we perform elective surgeries in neurosurgeries in Manaus, next to the river. Look at the Black River ahead. And this is the trauma hospital where our residents make the trauma module and make some duties. So most of the patients sustaining TBI, actually every patient sustaining TBI in the Amazon comes to this hospital when they need evaluation. So as you can see, we have many issues here. There are only CT scans in now, and one CT scan is in this trauma hospital only. There are no ICUs in the countryside, and actually, as you could see, the roads are at the rivers. And this paper that we published when we evaluate a city with 100,000 people in the countryside, with no CT scans, with no neurosurgeons. We evaluate these people sustaining TBI, and we saw that most of the cause of TBI were motorcycle accidents. And when this patient was admitted to the hospital, most of them were transferred, and it's about half of them were transferred through air transport, and the other half by the rivers, by speedboats or boats like this. And this other paper, we aim to evaluate who were those people reaching the tertiary hospital in Manaus that came to neurosurgical evaluation. Most of these patients were patients sustaining stroke or TBI, and they come from all over the states, as you can see here. But the most interesting point is that the mean time from the event to the tertiary hospital was 3 days. Overall, only 1/3 of these patients required neurosurgical treatment, and 43% had fast recovery without complications and no need for surgery or ICU admission. And what we concluded that the air transportation is vital for the Amazon region. However, it's very inefficient. As we can see, stressed by our colleagues, Ernest, Kipar, Franco, that the acceptable time to reach the hospital in low and middle income countries are 4 hours. So we have this first delay, that is a huge delay in our region. Other delay is when patient reach the hospital and wait for the CT scan. Here also we have some problems. Eventually the CT scan is broken. So we have to screen the patient to identify who are those patients who need a more fast CT scan. And the other thing is the third delay, from CT to surgery, where it can occur also. Here is the Amazon prospective cohort that we evaluate 467 patients. Look at the most patients are from the capital. As Rodrigo put that slide, the most violent cities in the world, Manaus is one of the cities that is in that slide. And look at the time of arrival at the hospital. And only 1/3 reached the hospital within 4 hours, showing this delay that we can see. Okay, here is the other variables. 41% of these patients required neurosurgery, and look for the interval for the surgery. And none of the patients that required neurosurgery received the procedure before 4 hours, stressing this problem in our region. And the other thing is, when we evaluate the mortality within 14 days, we have an overall mortality of 20%. However, patients sustaining severe TBI had an acceptable mortality of more than 70%, was extremely high. We have a bias in this collection due to it was performed during the pandemic. Look, this density of death of the admission and death, the death during the first wave here, and here the second wave. We are analyzing this data to see how the pandemic impacts these patients with severe TBI. We have just some illustrative case to show you what I find here. And this is, it can occur here in the Amazon, the city of 3 to 550 meters of height. And it has this fruits that's the kind of coconut that weighs almost 1 kilograms, and this fruit likes to produce epidural hematomas, and it's particularly severe in children. This is a case series of 7 patients sustaining this type of lesion. Here is a child that had this penetrating TBI with a wood stick from a tree during a strong wind. This patient evolved well. And we find here several cases of penetrating TBI that's uncommon in high-income countries. And because most of these patients generally evolve with sustaining projectile wounds. Here we also have this type of lesions with machetes, and producing this skull fracture, this linear skull fractures and contusions just related to the fracture. Here is not a machete, but this is a patient that fell from the tree, and he was with a jigsaw, and the jigsaw hit his head, leading to this frontal decompressive, as you can see there in the CT scan. Actually, certainly this patient lost his eye and had this severe lesion. He was good. He was with DCS of 14 when he reached the hospital, and he was operated in a standard fashion to correct the dural lacerations evacuated the hematoma that was most extradural, and he recovered well. And here's this a cohort of patients sustaining domicile TBI in the Amazon, as I told you, that's very frequent. We have now not 80 patients anymore, we have 110 patients now. In this cohort, many patients had this lesion through machetes, almost 50% of this patient. And the predictors of unfavorable outcome were diminished DCS, neurological deficit, and time to surgery. However, the independent predictor was the presence of neurological deficit. What is uncommon in TBI, but as this machete fractured the screw, the parietal screw, so it's more common to see neurological deficit, lateral neurological deficit. Also, we use here non-invasive tools, mainly the optic nerve shift ultrasound and the brain for care non-invasive ISP. We use the optic nerve shift ultrasound to screen patients to CT scan, and the brain for care to evaluate patients in coma or post-surgery. And just an example of a patient with a high diameter of the nerve shift, 6.5, that had a subaqueous subdural hematoma that was evacuated, the patient evolved with favorable outcome. And to conclude my final thoughts, as you can see, the Brazilian Amazon has to be considered as an underserved area. Brazil is a huge country, as Rodrigo, the center where Rodrigo Faleiro is located is very different from my center here. So there are a lot of disparities here in Brazil, especially in our region. And the diagnosis of the main weakness regarding the whole process of neurotrauma care in our state has been made. So it's urgent. We have urgent need to strengthen pre-hospital and intra-hospital care. So we are training our health practitioners, the neurosurgery team, and talking to the politicians and government to improve the infrastructure for telehealth and making some transfer protocols. And inside the hospital, we are using the damage control and the bootstrap protocol that Rubiano will talk a little about. Yeah, a very important in my opinion. So this would not be possible if I don't have this marvelous team. We have residents of neurosurgery and physiotherapists, neuropsychologists, and the staff team of neurosurgery here in our hospital. And also, I need given my patient given by Andres and my colleague, my inspiration given by my friend Nils and Dr. Andrade here in Brazil. So I'd like to invite all of you to be here in Manaus to swim with the pink dolphins and know the Amazon in 2025 in our Congress. Thank you so much for your attention.
Thank you, Professor Amorim. It was a great talk. And I just wanted to ask you something, because I think it's really an adventure then to have a TBI in the Amazon. So you talk about a mean transfer time of 70 hours. So really, you get patients that are not really severe, because the most severe ones would die in the transfer. And,
yes.
And then would you say that you are talking at the end of telemedicine? So you have all the other facilities around in the area that could help in the transfer. Could you explain a little bit if you have a transfer protocol or not from those other facilities?
Perfect, doctor. So we have some major cities in the countryside that actually have a covenant with the university, and when we have patients sustaining TBI and is during the day, so we can have this telehealth measure to talk with them and evaluate the patient's telehealth. However, most of the TBIs are in the weekends and nights, and there is a delay when we have this. And the other problem is that although there are these telehealth centers in these major cities in the countryside, most patients are in the rural side of these cities. So it takes longer for them to reach the main hospital in that city. So all the process is very challenging here. So we are definitely changing culture here, because most people here, most of the funding is for infectious disease, for example, and they forget about cardiovascular disease or trauma. As we can see that it's very burden for this patient.
So you see a lot of secondary damage, secondary injuries like ischemia or infection after having so long for the transplant?
Yes. We see lots of, when we perform sometimes the CT scan, there are lots of ischemia, areas of ischemia in these patients. So we are also evaluating the potential of this operative CT scan to predict outcome. That's one thing that we do not use in neurotrauma, because, well, the admission scan is okay for evaluate this, but I think that in low resource settings where the patient have so many secondary injuries, the post-operative CT scan is so important for us to talk to the families and evaluate, look, they have several areas of ischemia, and probably this patient is not able to evaluate to evolve with good neurological outcome. So that's an important issue that we are evaluating now here.
Okay, I don't see any other question from the audience. So I would like to now present Professor Rubiano, who has played a major role and made a super job in assessing the applicability and adaptation of clinical guidelines developed in high-income countries to low and middle-income countries, and to obtain consensus in policies that really change the outcomes of patients, such as stratified protocols to guide physicians. And he's going to talk to us precisely about this very important topic. And so please, Professor Rubiano, Andres, thank you for coming and organizing these talks. And please, it's now your turn to talk about stratified protocols in TBI management.
Thank you, Alfonso. Thank you so much for your moderation. And also thanks again to Professor Reisner and Professor El-Ghandour for taking the opportunity to invite all these crowd of experts, especially from the Latin American region, and other invitees like Professor Gano and also Professor Alves that are participating into this excellent session. So I'm going to share briefly the concept of the stratified protocols, and I think will be ideal due to the amount of questions that have been posed in the audience. I don't have any conflict of interest, just to understand that many of the things that we present here are part of the Global Health Research Group of Neurotrauma research strategy that have been developed by the University of Cambridge, supported by the NIHR and our local research center in Colombia, Fundación Meditech. So we all know that we try to practice under clinical practice guidelines. We know these documents incorporate recommendations based on evidence or based on expert consensus that in ultimate seek to reduce the heterogeneity in clinical practice. Many of the questions that we have in the audience right now have been specifically that we have many heterogeneity according to the level of resources, according to the experience, according to many of the literature that is available. And we have several questions regarding the decision-making point on every one of these different cases that have been presented. So they are generally built through robust methodologies to select the best available evidence on specific interventions in the management of a pathology, and in this case, in the management of TBI. We recognize, for example, the international and global reach of the Brain Trauma Foundation guidelines. Recently, we have the national guidelines for TBI management for the India Society of Neurotrauma. We have some other examples here, the local guideline for the Ministry of Health in Colombia, what we will develop in conjunction with the Cochrane Group and also with the BTF, and some example of the Japanese guideline for the management of head injury. So we have several guidelines out there. These guidelines establish rigid recommendations with or without bias control, which are generally not very specific and leave a lot of gaps where there are no studies that support the intervention. So we are familiar with that type of recommendation that we need more study, there is no evidence. So when we are going to translate that to everyday practice, we have a huge barrier because we don't have a specific recommendation for something that we found in the field. So in order to fill these gaps and be able to translate the recommendations into clinical practice, it is generally necessary to additionally build expert consensus on topics where there are not solid studies and subsequently build protocols with flowcharts or algorithms that take us to the specific point where we are practicing in every one of our centers. So it is important to briefly mention the difference between protocols, consensus, algorithms, and flowcharts. So we understand that the consensus generate recommendations arising from the agreement between professional experts in a given subject and are generally endorsed by the scientific societies. These consensus generally include broad participation from different stakeholders and a lot of experts in the field. The protocols establish a series of procedural steps or agreed rules for the clinical management or surgical management of certain health situations. The algorithms allows us to indicate the decision-making flow in these protocols and may be included in other documents such as consensus or guidelines. So many times these terms are used interchangeable, but really each one have their own function and their specific objective. We have two big examples here in the field of neurotrauma. The consensus statement from the International Consensus Meeting of Decompressive Craniectomy in the Management of TBI. This was a bunch of experts worldwide from different regions, even high-income settings, middle and low-income settings, that they put together some recommendations when to perform the procedure. And also we have the consensus statement for the International Consensus Meeting on Post-Traumatic Cranioplasty that was discussed here by one of the speakers, and also was a bunch of experts presenting their experience and putting together some recommendations. So these are very good examples of consensus-based decisions. We have consensus that finish with a specific algorithm, like this recent consensus for the World Society of Emergency Surgery. It's focused on what to do when you have a TBI patient that also have a polytrauma, systemic polytrauma, because many of the other recommendations from guidelines are based only on patients that have TBI isolated and didn't consider the possibility of have polytrauma with multiple injuries and bleeding from other sources other than the scalp or the skull or the brain. So this was also a bunch of experts, including trauma surgeons, intensivists, emergency physicians, and neurosurgeons, putting together their expertise in order to build, at the end, this small algorithm that has been presented for this consensus. But this algorithm is useful only if you have many of the resources that are described there. Most of these people come from areas that have all the resources. Another example of algorithms made by consensus are the recent CIVIC ones. The one that is for TBI care guided by invasive ICP monitoring, bunch of experts also that are very familiar with the technique of managing this patient within this environment, and they develop in a specific algorithm that is now available under the Global Neuro Foundation group in many different languages. And also the CIVIC2 that include, plus the ICP monitoring, the brain oxygen tension monitoring, and develop also an algorithm that can be used in any region that counts with the technique. This is another protocol that was developed by consensus. So this is not an algorithm, it's a specific protocol developed by consensus, is the famous CREVIS protocol that is TBI guided only when you have a CT and the clinical exam. It's for centers that does not have access to an ICP monitoring invasive or the oxygen tension monitoring invasively. So For a question, for example, that was done, when to do a decompressive craniectomy and how do you make the decision-making point for performing a decompressive craniectomy, this is a good example. This is a protocol developed for managing patients only based on clinical examination and clinical and the image, the CT. So this is a good consensus that you can use in order to define a decision-making point for a decompressive craniectomy if you don't have invasive monitoring, talking about performing a primary DC other than a secondary DC. So what do we have in the field until now? We have evident consensus-based guidelines in different countries with different set of questions answered, different recommendations, and different contexts. So we cannot do or apply directly many of the recommendations in areas with high resources to areas with low level of resources, or vice versa. We have expert consensus for specific topics, in this case, when to perform a decompressive craniectomy, when to perform a post-traumatic cranioplasty. We have one protocol for managing patients with CT and clinical examination, one consensus for managing patients with polytrauma and TBI in high resource settings, one algorithm by consensus to manage patients when you have ICP monitoring invasively, and one algorithm by consensus when you have patients that can be managed with invasive ICP and invasive PTIO2. So if you have any of these contexts, you can apply one of these documents. But if you go to many regions in the world, the situation is that even in one center, you can have many variations during the time of the year. And there are centers that not all the time have available the CT. There are centers that do not have available all the time an ICP invasive monitoring, or there are centers that do not have all the time available an ICU bed. So the question is what to do when you have that kind of variability or heterogeneity. So I just present this with these different type of shoes according to the terrain, because it can make a mimic of understanding better what to do. So depends of the terrain where you are walking, you are gonna need some pair of shoes that will be more comfortable for you walking during that process. And the real issue is that one size does not fit all. So if you only have one pair of shoes, it will be very difficult to move in all those different terrains, and some of them will make you very uncomfortable working into those terrains. So the idea is to try to make you easy your life and try to work comfortable in every one of these different situations. So the stratified protocols concept comes to have several options on each category of intervention. So you can have a lot of shoes in order to decide which pair of shoes you wear best in order to walk in a different type of terrains. In this case, walking on different environment for different type of TBI patients according to the resources and the variability of the resources that you can have in your center. So we published some of these recommendations. It was made by consensus, and those consensus finish also in algorithms and specific protocols that are available. So I always mention to the people that when you arrive to the article, the important thing is not the article per se. The important thing is the supplementary material that is available, because it includes the specific protocols of care other than the algorithms that are described in the article. So the general idea of this is that wherever you are, you can have in the pre-hospital setting, your patient can be managed by a very low resources unit with very low level of training of the providers, or you can be in a unit that has some of the resources or some of the training, or you can have access to a unit that have all the resources and all the training. And then you move to an emergency room that can be with CT or without CT and with the same approach. You can arrive to a center that doesn't have any resources or low level of training at the emergency department, some resources or some level of training at the emergency department, all the resources and all the training at the emergency department, but in this case, without a CT, and in this case, with a CT. And then you can move to centers that have neurosurgeons for emergency surgery or have other type of surgeons like general surgeons or trauma surgeons for emergency surgery. And then after that, you can move to an ICU with all the resources or to a center that only have lower level of complexity for postoperative care, even an intermediate unit or just a general ward. So that's the real world situation. And the idea is that you can have protocols that can make you easy to move between these different levels of heterogeneity in one health center. So these protocols are full of tables and are full of useful algorithms and also useful tools like this is the trauma checklist from the WHO that is very useful for emergency departments in general, and we do not generally use that, and it will be very helpful and supportive for a TBI patient. And if you go over the specific protocols, they have different set of colors. This is very important to navigate within these protocols, because if you are in a center that does not have all the resources, you just go by the red color, that is the very basic one, and you follow the red recommendations. If you are in an intermediate center, you can go over the black recommendations that are the middle one. And if you are in a very advanced center, you can go over the green recommendations that are the very advanced ones. So very easy to navigate into those protocols. So where we are now is we are testing in the field the impact of using those protocols. So we are in the specific study right now, doing a comparison study, a quasi-experimental before and after intervention. We are in the second phase, finishing the process right now. We are going to publish that soon after analyzing all the data in a network of hospitals in Colombia that have been using the protocol for some months ago. We also have been into the process of analyzing in deep with Dylan Griswold. Dylan Griswold is a PhD student for the University of Cambridge that have been deployed in Colombia for a couple of years, just dedicated to investigate and do advanced research into this specific topic. And we are evaluating what is published in the literature related to the impact of this kind of resource stratified protocol development, and if maybe the guidelines will move in the future to this same approach. So these are the three centers that are involved now in the study in Colombia, one in the southern region with a very low level of resources area. We have one in the middle of the country, and we have one more northern. And we have been taking data into this center that have a lot amount of TBI patients in order to finish the study. So at the end, the main message or the take-home message is we are different societies, we are different groups, we are in different areas of the world, but the TBI physiopathology is the same. And what we have a lot of heterogeneity is what we think as neurosurgeons taking care of these patients on what resources we have in order to take care of these patients. So what we need to decrease is the heterogeneity in taking decisions according to this concept that we have in our local knowledge and also in our local resources. So this is an open invitation to many of the societies and groups that are producing guidelines right now and protocols for the care of this type of patients in order to unify and move to a more structural approach that can be very useful for the everyday decision-making point in the field. So thank you so much.
Thank you, Professor Rubiano. It's a great talk about a really great idea on how to apply protocols on different areas depending on resources, and specifically in things that will change the outcome of the patients. I would like to ask you, you just mentioned that you are doing an implementation study. I guess that you will also try to ascertain the application of the protocol in each side. I mean, even between among different physicians, there will be sometimes differences in applying the protocol. Can you talk about that a little bit in your experience in your centers?
Yes, totally. I think actually I was talking with Dylan, and he's very motivated to do an additional research into what are the barriers and facilitators for the implementation phase of the study. So what we have been understanding is that this make a lot with what we call the local ecology of care, and it means with the human issues, you know. That when you try to work with checklists, when you try to work with the specific protocols, the adherence will have a lot of variation just because we are humans. And it has been tested also in other issues like the checklist for the trauma care checklist of the WHO when we do the implementation study for that. And we arrived to some emergency centers and we asked some physicians in many regions of the world, why you don't use the checklist? And they say, I didn't use the checklist because I was not invited to participate in the elaboration of that. Or they say, I don't use the checklist because there is some person there that I didn't like it, so I don't use it because of that. Or they say, I don't use the checklist because I don't want to change my practice that I've been doing for the last 30 years. So all those issues needs to be have to do with human issues, not really with the science issues. So people sometimes do not apply these kind of tools, not because they don't think they are useful, it's only because they have human issues against the tool. So those barriers and implementations are very important, and definitely, as you mentioned, we are taking note of all these in order to put that in a paper soon to describe the experience going into that.
I guess that these kind of protocols have been designed not just by neurosurgeons, but also from ICU people and from different areas as well, and different specialities.
Yes, yes, totally. We include emergency physicians, we include paramedics, pre-hospital providers, we include intensivists, all the people that are involved in every one of the stages of care. And we are, with the support of the World Federation Neuro-Traumatology Committee and Professor Reisner, we are moving the idea of developing something similar for pediatric TBI and also for spine care, for a spine injury, because we consider that will give an interesting approach of how to tackle these conditions worldwide.
Really interesting. I would suggest for a problem in Europe we have now, go to the elderly as well, not just pediatrics, but I just you know why. But it would be a good idea too.
Oh, totally, totally. Thank you for the suggestion. I know Professor Reisner is taking notes of all these.
Yes. Just two quick comments. One is a quick thank you, Andres. Your work is just life-changing to so many people on so many continents. On a more local level, Alfonso, I think you'd be interested to hear when we implemented our severe TBI pathway, and we never had one about 15 years ago. As Andres said, you do have to have the human factors, and everybody was involved, administrators and nurses and all the rest. And so that was the carrot. But I really think, and you may or may not agree with me, you kind of need a stick as well. I went to the medical executive committee, Andres, and this is our protocol. They approved it. And we did have some crazy ICU doctors and some crazy neurosurgeons that were doing things that were just ridiculous. But I couldn't stop them without having the hospital board. And so it was reported. If they did something off the protocol, they would have to go to peer review and explain why they did it that way for every patient which had an outcome, a bad outcome. Now, that said, it was open. If they had a great idea, obviously we don't know everything. They could come to us and we change the pathway. But unless you implement it, and you're right, Andres, it's the human factors as much as scientific factors. Just having a piece of paper and handing it out or pathway, you've got to implement it, and you've got to have a champion to do that. And I'll stop right there. Thank you.
No, totally. In the experience in these centers that I show, that was necessary to turn that into an institutional policy, according to what you mentioned, in order to have some control regarding those adherence that needs to be increased in the centers.
Okay, thank you so much, Andres. And now I think we are going to move on to Professor Wellington Paiva from Brazil. He's really an expert on neuromonitoring, having published a number of very interesting papers on the measurement of intracranial pressure and its pathophysiology, as well as the monitoring of cerebral hemodynamics. He's going to talk about all the forms of neuromonitoring. So please, I don't know if Professor Paiva is with us.
Yes, I'm here.
Okay, so he's going to talk on non-invasive neuromonitoring in TBI, please.
I would like to thank for this opportunity to talk in this amazing educational symposium. And I would like to thank Dr. Andres Hasner and Andres Rubiano for this invitation. I will share my screen. Okay. Then I will speak about a very important issue involving traumatic brain injury management. That it's ICP monitoring. It is a central core of the management of patients with traumatic brain injury and specific non-invasive ICP devices and ICP monitoring techniques. It's important that ICP monitoring, it's a central role in the management of traumatic brain injury, but it's important in the other acute injury of the brain, like intracranial hemorrhage, subarachnoid hemorrhage, cerebral edema, hydrocephalus, and other acute injury of the brain. The standard of care in the monitoring of ICP is using catheter invasive systems for monitoring ICP. But it's important to mind about complication, the possibility of complication in using of these devices, and another important aspect that's involving costs. And for many of us that work in countries with low to middle income countries, costs is a very important concern in the management of these patients. The guidelines, as Andres talked about for me, it's important because the main guidelines, or the most important guidelines, do in high-income countries for high-income countries management of these patients. But traumatic brain injury, the most of patients, and the many of patients with traumatic brain injury are from low to middle income country. Then we need to create new protocols or adapt protocols to management of these patients in countries with low research to management of these patients. And in this context, the non-invasive techniques, it's a very interesting techniques for very interesting option to management of these patients. It needs new protocols for low developing countries, as Dr. Andres Rubiano told before me. For monitoring of ICP, there is another several techniques involving neuroimages, metabolic changes, indirect ICP monitoring com school elasticity, neurophysiology techniques, and the cerebral blood flow analysis using transcranial Doppler. There are several techniques for use of this monitoring of these patients. In the current guidelines of Brain Trauma Foundation, the management of severe traumatic brain injury patients using ICP monitoring is recommended for reduce in-hospital mortality. And this recommendation is from results of a BEST-TRIP trial. That's now a classical trial, but we have concern about the interpretation of the results of this trial. This is a very elegant paper published last year for important names of neurocritical care colleagues discussing about the importance of ICP monitoring in the management of these patients. But the invasive ICP monitoring is the standard care for our patients, but it's important to remind about the risk of complications. Around 10% of patients submitted to ICP monitoring has complications involving hematomas, infections, or dysfunctions of the devices. Then the idea of use of some techniques to screen how the best patient to to be submitted to invasive ICP monitoring, it seems interesting the use of non-invasive non-invasive ICP monitoring. If we don't have the standard ICP monitoring for all patients, it's very common in countries like Brazil, Africa, Asia, and some parts of east of Europe. We think that it's important to use non-invasive techniques to screening these patients that needs ICP, invasive ICP. I will speak about 4 techniques that are other techniques: transcranial Doppler, optic nerve shift diameter, pupillometry, and a new specific technique that we have in Brazil, for carrying non-invasive ICP. A transcranial Doppler, it's traditional, it's important techniques for subarachnoid hemorrhage, but for traumatic brain injury as well, and possible to use a transcranial Doppler to ICP estimation using the classical pulsatility index. We have studied the use of these techniques in animal models and in clinical setting as well. The advantage for use of transcranial Doppler is the analysis of cerebral hemodynamic evaluation in real time, avoid unnecessary hospital dislocation. That is a very important aspect of management of our patient, because most of many of patients has intubated with mechanical ventilation, and the risk of complications in transfer and dislocation is an important concern for these patients, and has low costs. That is important for all ICU, and specifically for us from low to middle income countries, but has drawbacks. It's necessary experience for the doctor that perform the exam, and the use of pulsatility index and other information from transcranial Doppler remain with controversial results in the ICP estimation. Pupillometry is another technique. It's a very interesting technique, a non-invasive ICP monitoring, and they base it on the velocity of contraction, a pupil contraction. There is literature about the use of this technique with the use of neurological pupil index, with correlation with invasive ICP monitoring, in the several papers studying this technique. And this is a very interesting paper published by colleagues from Italy that showed the correlation about the neurological pupil index and outcomes with patients with acute brain injury in the short outcomes and short follow-up, but it's a very interesting use of this technique. The problem about the use of pupillometry, it's a limitation for using confused patients, eye injury, light variation in ICU or in emergency department can interfere in management. In patients with diabetes, it's a problem as well, specifically chronic condition of diabetes. The use of optic nerve shift, it's a diameter, it's a simple technique with low learning curve that it's possible to use for emergency doctor and in ICU. It's a very interesting. This is a photography that it's possible to see the eye and the nerve and the optic nerve shift. And the idea in the last 5 years, a lot of papers studying these techniques in severe acute brain injury. It's very interesting. It's a very important interest about this new technique and the literature. But the classical study that Soldatus showed the correlation between 5.7 millimeters associated with intracranial hypertension It's not a static number. Other publication, other studies showed something around 6 millimeters correlated with intracranial hypertension, and for pediatric population, 4.5. It's a very interesting. Our group published last year this interesting study when we analyze the dynamic change in the optic nerve shape, and it's possible in animal model to see change after intervention after 5 minutes of this intervention. This is interesting, but it's needed to study in clinical settings to analyze it's possible to translate this information directly for clinical practice. Other important question is the measurement of optic nerve shift may predict mortality or outcome in TBI. This is a very interesting paper using CT, but showed important correlation with survival analysis between dimension of optic nerve shift and survival evolution of this patient in mortality of these patients. It's a very interesting aspect of use of this technique because it's possible to have ultrasound or CT even in low-income countries, low-income settings. The advantage of this technique is it's possible evaluation in real time. As transcranial Doppler is possible to avoid unnecessary transfer into hospital transfers, have low cost. Different of transcranial Doppler has a fast learning curve. I think that with a 10 or 15 cases is possible to do with it's a safe with experience about these techniques. It's a fast exam that interesting correlation with high ICP. The drawbacks, it's not possible to continuous monitoring, and maybe the most important, it's unsettling related with latent time to change in optic nerve shift diameter. We show that it's possible in the animal model, but will still unsettling the use in the clinical practice for the change in dimension of the optic nerve shift after intervention for control of intracranial hypertension. This is a specific case, patient male, 45 years old, car crash, 4 points in Glasgow Coma score. The tomography showed brain swelling with subdural hematoma. The transcranial Doppler showing the high pulsatility index, and optic nerve shift with 6.4 correlated with intracranial hypertension. Then it's possible to use of these techniques for analyze the efficacy of intervention for use of these severe traumatic brain injury patients. And the last technique that I will speak is about brain for care non-invasive ICP monitoring. It's a Brazilian technique developed by the Dr. Mascarenhas. It's a Brazilian engineer that it's based in the soft chains in the school, the bone school. It's possible to detection of this soft chains in this bone vibration, and it's possible to amplification to construct qualitative analysis of ICP using waveform ICP curves with base. And there is an interesting study that compare the waveform from ICP, invasive ICP monitoring with this device, and the interclass coefficient, it's high, close to 1. And it's interesting because some information like the relation between P2 and P1, it's associated with information about the intracranial hypertension. Then it's possible to use this technique to analyze compliance with analysis of curve, but some indirect analysis is possible to associate with intracranial hypertension. Our group have studied and published this paper analyzing 41 patients with severe traumatic brain injury and analyze the changes in the curve of ICP, an important the correlation between invasive and non-invasive ICP monitoring and changes in measurement like compression of jugular compression and changes in position of the patients. And there is an important correlation between invasive and non-invasive devices. In this another paper that we published, we analyze important aspects that it's we involved 15 patients with the compulsive craniotomy that we need to know about the use of this technique in patients with school fracture school opened school and we showed that important correlation between non-invasive and invasive correlation of this ICP in this study analyzing 57 patients. This is another study that we are analyzing this kind of non-invasive pressure waveform for estimation ICP, but for prediction of outcome as well with these patients. We analyzed 72 patients and we found association between this relation P2, P1 and correlation with follow-up. It's early follow-up of these patients involving mortality and recovery, but only for early follow-up of these patients. And it's seeing interesting technique. Now we are doing a multi-center study to analyze this application of this technique in practical in a large number of patients. We have recruited now 250 patients. The idea is to recruit something around 400 patients, and I think that it's a very interesting these results that I think that in 6 months or 1 year we have interesting results to discuss about this technique. In this multi-center, we analyze patients with severe TBI. We are excluding patients with craniectomy, but included 5 Brazilian centers, including Manaus, Belo Horizonte, Rio de Janeiro, and São Paulo. João Pessoa, involving many of professors of this course in this multi-center study. This is comparing the curve form in analysis, large time analysis with a similarity and no-invasive and invasive technique. And it's possible to do a comparison with estimated PRX for these patients using invasive and non-invasive technique. For this technique, with advantages, a continual real-time evaluation of ICP curves, real-time, using possibility of non-invasive PRX, relative low costs, and the possible use of this technology in different scenarios. The drawbacks, now we don't have absolute ICP number, and we use for ICP monitoring, which are qualitative ICP monitoring, but not quantitative ICP monitoring, and some difficulties necessary, some experience to put the sensor in proper position ahead of the patients. We think that these tools may be useful, especially for patients with TBI, severe TBI, but despite our enthusiasm, some of these techniques needs more studies to understand the specific indications and the specific use in clinical scenarios. But there's tools important, especially in countries with low research, because it's low cost, fast, and usually fast learning curve for use of these techniques. Thank you.
Thank you so much, Professor Paiva. I would like to ask you something related to your superb talk. I would like to ask you about what would be the technique that you would recommend to a physician that needs another way of measuring ICP and has not the resources. What would be the most advantageous technique regarding reproducibility, maybe, and the economics?
I think that all non-invasive devices has advantage, and specific for screening for the patients that need invasive, non-invasive ICP monitoring, and it's difficult to define how specific type of non-invasive technique we need to use. But I think it's necessary to training, and I think that there's some information using optic nerve shift or brain share or transcranial Doppler. It's important the sum of this information for monitoring for ICP doctors for management of this patient.
And I would like, there's some noise around. I think it's Professor El-Ghandour, I think. Sorry, I didn't catch the way this brain for this new technique you are presenting of non-invasive ICP monitoring. What is the basis for the measurement? You talked about the pressure in the muscles, or is it the vessels? Is that something related to hemodynamics of the skull? What is it about?
It's this location of the bone. Yes, okay. This suture. Important to put the sensor under the bone position, not in the temporal muscle. It's important. The idea is to detect the soft dislocation of the bones during the time, and it's very interesting because it's possible to detect this change in patients, even patients with normal pressure. Because
so the skull is not closed in the adult.
Yes, but
not really closed.
Yes, but even in the adult, there is a soft dislocation of the bone, and with P1, P2, with systolic, and this soft dislocation is possible to detect. That it's an adaptation of old technique developed in Colombia in the 80s, called Colombian crown. That it's like a stereotypic but the idea now is to convert it for no invasive, different for minimal invasive technique. But it's possible. I have some enthusiasm for use of this technique, but now we are studying the possibility of use of this technique, not for clinical practice, for clinical application immediately, but it's a very interesting for studying this technique to understand about this technique and the found what the specific patients can have benefit to use of this technique.
Okay, thank you so much. I feel that there are no more questions. Is anybody going to ask anything else? If not, thank you so much for this very interesting session. And I'll pass over for Professor El-Ghandour and Andrew Reisner and Andres Rubiano to close this wonderful webinar. Thank you so much.
Thank you, Alfonso, very much for this excellent moderation. Now I give the mic back to Professor Andrew Reisner and
I'm just okay if I go first. I just want to thank you, Professor El-Ghandour, again. If it wasn't for you, none of us would be here today. It's as I watch the numbers get bigger and bigger, I wonder what we're going to do for webinar number 100. Maybe we should have a webinar on all your accomplishments for number 100. That's just an idea I'll give out. But in all seriousness, thank you to the moderators and the panelists, and perhaps most importantly, the participants who asked excellent questions and stayed with us for the last 3 hours. This was just a fantastic webinar. I learned a lot, and I hope everybody else did too. Thank you so much.
Thank you. Thank you very much, Professor Robiano.
Yes, I'm just typing some of the final answers for the chat. It has been very incredible to have all these more than 230 people in 3 hours, Professor El-Ghandour. So congratulations. I think you are going to have a hard work getting all these certificates. There are some questions regarding how to download the certificates. Thank you to all the participants, the speakers, the moderators. It has been an excellent webinar that will be posted online for future access. And definitely the idea is that there are several conditions around the world that allow us to improve care for TBI patients. I was just answering for some people in Afghanistan that are asking how to getting more familiar with ICP issues if they are not invasive access to ICP monitoring. Maybe the talk of Dr. Paiva with the non-invasive technique will be very helpful in order to start getting familiar with this. The brain for care technology that has mentioned is something that it gets a little bit interesting, focusing on the concept of the cranial compartment syndrome, interpreting and correlating the ICP waveform. And thank you so much. Thank you, Professor Reisner, for the hard work with the Neuro-Traumatology Committee of the World Federation that is trying to improve the care of the patient worldwide. So.
Thank you very much, Professor Robiano. I think now it is time to close the webinar. I'd like to thank all our distinguished speakers and the moderators and participants. Thank you very much.
Thank you, everyone.
Thank you.
Thank you. Thank you very much. Thank you for the invitation.
Thank you. Thank you very much.
Huh?